शेवटचे लागले या साईडला त्या साईडच्या पोर्शनवरती आणि मध्ये नेफ्रेमध्ये लागले आणि पावणे तासाने सॅमसंग सगळे सेम बॉडी आणि सेम साईज पोडियम बघू पोडियमला पण एलईडी लावली मला वाटलं आणि तो हे बॅनर आहे त्यानंतर प्रोजेक्टर हे डायरेक्ट त्याला पण एलईडी लागली आणि जे लेफ्ट आणि राईटला जे आहे ना एलईडीच्या हा कोपरा आणि तो कोपरा जिथे दिले ना असं ही स्क्रीन जरा नीट बघा मला तेवढा फरक दिसेल मधल्या एवढा मोठा आणि लेफ्ट अँड राईटच्या स्क्रीन मध्ये छोटे छोटे बॉक्स आहेत आता ते लिहिले ना आता तुम्हाला आता येईल ना हे लिहिले ना 22 मुंबई लाईव्ह ठीक आहे आणि खालीच्या बॉक्स मध्ये होस्टेड बाय रिलायन्स तो जेवढा बॉक्सचा स्क्वेअर आहे ना हा एवढा तो बाहेर येतो एलईडीच्या आणि मग आतमध्ये जातो तशी वाली एलईडी आहे मधला नाही आहे आपला हा सेंटर वाला नाही लेफ्ट अँड राईटचा आहे मस्त आहे आणि हा ते मध्ये पण आहे ना जे गोल सर्कल अर्थ ते पण एलईडी आहे काय ना तुझ्याकडे फोटो पाठव आम्हाला फक्त हा सामान जमा करायचं आम्हाला फोटो पाठव आणि आयटम बघ ना उघडून पाठव कोणी आम्ही सॉफ्टवेअर बघ कोण असेल आयटी वाला तर पाठवून दे आणि ते फोटो पाठव ना फक्त
Hello. May I have your attention, please? A very good morning, ladies and gentlemen. I welcome you to the last day of the 22nd Mumbai live endoscopy course. It's heartening to see so many of you on otherwise lazy Sunday morning. Coming together is a beginning, staying together is progress, and working together is success. Without further delay, we begin with our first session. May I request you all to please put your mobile phones on silent mode? At the outset, I would like to invite the chief moderators, Dr. Nitin Pai, Dr. Nilay Mehta, and Dr. Saurabh Mukhewar, to please come up and be seated on the other end of the dais. And as chairpersons for the endoscopy update date, I would like to call upon Dr. Mufazzal Lakrawala, Dr. Ishwar Havannavar, Dr. Rinkesh Bansal, Dr. Ramesh Satarkar, Dr. Vedant Karvir, Dr. Daksh Khurana, and Dr. Anataku Agasti. May I request you to please come up on the stage and be seated in the center of the stage. A slight change in the program, as has been printed, is that Dr. Stephen Seawald was unable to join us because of some visa issues. We have his pre-recorded lecture, which will be played first, and that will be followed by Dr. Ino's lecture. And Dr. Mohit Bhandari also couldn't make it, so we have enough time for discussion. People who have lots of questions from yesterday from Dr. Ino's talk can also ask those questions during this session. So I hand over the session to the chairpersons to first announce the first talk by Dr. Stephen Seawald, or I would do that. Dr. Stephen Seawald would be lecturing on managing leaks, perforations, and fistulae, the new tools for the GI endoscopist. And after Seawald sir's lecture will be Dr. Ino's lecture. Thank you very much.
Yeah, Amit, thank you very much for the invitation to 22nd Mumbai Live Endoscopy. Unfortunately, I cannot be there in person because the Swiss airline literally rejected me from the flight, even I have been holding a valid visa. However, we can classify this as a small complication compared to the huge complication. I'm going to talk now about fistula perforation and leaks. And I would like to discuss with you now some new tools and aspects of endoscopic treatment of these conditions. When we look at leaks and perforations, I have to admit that the endoscopic vacuum therapy has tremendously developed as a life-saving therapy in the past years. And as you can see here, this is a 35-year-old patient with a rectal cancer. He developed an descent of the anastomosis with a large cavity. And after cleaning this cavity, we started with an endoscopic vacuum therapy. And you will notice already after the first sponge exchange, we can appreciate there is granulation tissue. So in this patient, we performed the sponge exchange 10 times over a period of 4 weeks. But finally, we were successful. This is the result after finishing the endoscopic vacuum therapy, and this is the result 12 months later. When we come now to the tools, there is a little bit discrepancy between inexpensive and expensive. I'm still more a fan of self-made products, but there are very interesting new tools on the market. When we look at the commercially available endosponge sets, we have one set for the esophagus, another for the rectum, produced by Brown Company. However, Brown Company, the sponge business of Brown Company has been taken over by Boston Scientific. And I think now these sets will be internationally available and help to treat many patients with leakages. Let me show you now another example with a patient with an intramucosal cancer in the biopsy of a Barrett's esophagus. In this patient, we performed an ESD. Looks quite nice, but what I didn't tell you, this patient had 2 times a kidney transplantation. He was under immunosuppression with several medications, and he also had a cellular immunodeficiency syndrome. When we scoped this patient 7 days after endoscopy, we experienced a disaster. This was one of my darkest days in endoscopy. There was a large perforation, and when we entered here this perforation site, we ended up in a large mediastinal cavity. In this patient, we cleaned up the cavity, and then we started with an endoscopic vacuum therapy. As you can see here, so we are here just placing the sponge into the cavity, and then we changed the sponge every 3 days, finally 12 times over a period of 3 weeks. And also in this case, nicely granulation tissue developed, and this is the final result in this case, so the cavity could be completely closed. And this is the result 5 years later, and here you see the patient and his happy doctor. When we are performing endoscopic vacuum therapy over a longer time period, we run into the problem with the oral feeding of the patient. And that's why we are using very often so-called Trillumina sponge systems. These are regular Fresenius Trillumina systems where we place sponge material around the gastric opening, here with polyurethane material, and here with a specific drainage film, which is very convenient for the patient. And another advantage is that this Trillumina sponge system can be now directly placed through the nose. A further development of this system is the Suprasorb CNP Endo. These are systems, also nutrition systems, where you can individually place your sponge into the area of the defect, and you can also flexible position the nutrition tube. So this is a system which is now available about 1.5 years in Germany. And the latest development in this field is the vacuum stent from Microtech. This stent is available for the esophagus with a length of 5 centimeters, and also for the colon with a length of 60 millimeter. And I think this is a very interesting device, because for sure there's discussion now if we use this system, maybe we can prevent the placement of a stoma before colorectal surgery. So this is a paper with 12 patients. Bug stent was, in most of the cases, placement was successful, and anastomotic leakages could be successfully treated with this system. Let me come now to perforation. Perforation for sure can be a complication, like you can see here. This is a patient with a sessile serrated adenoma. Here you can appreciate the muscle defect, the typical target sign. Situation, we have a bleeding and a perforation. So in this case, we started to close this defect by clips. In this case, we used Cook clips, and in such a situation, it is important that you really get a proper full layer adaptation of the perforation site. Here in this case, after the placement of the first stent, we already had a good overview. Here we are placing a second stent, a second clip, and finally a very interesting development is the Mantis clip from Boston company. This clip has specific anchor prongs, and these anchor prongs may grab tissue and oppose this tissue to the other side of a defect. And in procedures where perforation is a part of the procedure, these clips can be used very effectively. This is a nice case here where we have an open perforation during a resection of a GIST. Now you can appreciate how we grab a tissue with this Boston clip and we bring this tissue to the other side of the defect, and then because there is still the tissue in these prongs of the clip, we can nicely adapt both sides here of this perforation, and finally we can really nicely, successfully close here this defect by Mantis clips. There are several other clips like from different companies. We should also not forget the OTSC Neo system with a twin grasper, which is very effective in closing of perforations below 2 centimeters. And I would like to show you now another very complicated case. In this patient, we only marked a early cancer lesion and in the stomach, and then we noticed only due to insufflation of CO2 we experienced the full layer perforation. This is also a patient after kidney transplantation. So in this case, we used the string clip suturing method from Professor Yahagi. You can appreciate that the thread is fixed on one arm of a clip. Then this clip together with the string is fixed on one perforation margin. And now the second clip is placed on the opposite side above the string. And now you can pull on the string, you can cause tension, and this effect guarantees that both layers of the defect, both sides of the defect come together, and now you can more effectively clip and close this perforation with other clips. Another system of closing perforation is the stitch-based closure. There is the new Boston Overstitch NXT system for single-channel endoscopes. I think you have seen this at the Boston Lunch Symposium, a very interesting technology. I would like to highlight another system, the rolling stitch from Endorobotics company from South Korea. I think this is a system of the future. The advantage of the system is that the needle can be changed between the two arms. And another advantage is that the needle holder can be moved flexible around the tip of the endoscope. And here you see the advantage because this needle can be changed between the two arms. The stitching direction can be individually adapted and changed very quickly. And I think this is a very promising system so far. Finally, let me come to fistula. What is new in fistula? There are two interesting papers, one from the group of Guido Costamagna, where in a bronchoesophageal fistula, so-called autologous microfat was used, which was produced by subcutaneous tissue with a specially designed microcannula from the same patient. This fistula could be successfully treated. And another interesting approach are these occluders for GI tracheobronchial fistulas, and these occluders can be placed through the scope. Finally, I would like to thank again Amit and his great team for the invitation to this workshop, and I would like to congratulate you to this successful workshop. As you know, we are both part of the Sahendra family, and in the past year, Amit supported us a lot with our little endoscopy workshop, Endoswiss, which take place every 2 years. Amit performed live transmissions to Zurich. He visited us in Zurich, and also on our YouTube channel, he has, with his procedures, the most clicks. So thank you very much for your great friendship, and I would like to announce our next Endoswiss meeting in June. We are also streaming this event. You can follow us at the Endoswiss app, and there are also several hot topics with regard to vacuum therapy, to suturing devices, and one highlight will be the endorobotics demonstration in Europe, the first, the novel technology for endoscopic resection and closuring of defects. Thank you very much for your attention.
Since it's a pre-recorded lecture, so I don't think we can have any questions. So, sir, you can invite the next speaker, the first one rather. Dr. Inoue, please. Dr. Haruhiro Inoue will be talking about PPI-dependent GERD in evolving endoscopic therapies. Over to you, Dr. Inoue.
Yes. So, good morning, and thank you very much for this opportunity again. And then I'd like to talk about the anti-reflux mucosal intervention. I'm P, so we can say that I'm X. Anyway, so coming back to the 2003, I have reported that the artificial ulceration at the level of esophagogastric junction and the gastric cardia, which induce the tight shrinkage of the junction, which can avoid the reflux disease. So then, we report
Dr. Inouye, can you come to this side? We can see here on this laptop. पर यहाँ पे अच्छा ठीक है.
Oh, may happen. So it's okay. Hopefully, yes. Then 2014, so 10 years ago, we reported the ARMS procedure, anti-reflux mucosectomy procedures. The 3 years result is acceptable. The patient keep a good condition after procedure. Then we are switching to ablation. So the purpose of this mechanism of this technique is creating the ulceration, and then it's a healing process, the shrinkage, natural shrinkage of the ulceration make the junction tight. So in order to get that purpose, so ablation also works well. So compared to the mucosectomy, ablation is a technically very simple and easy. Any endoscopist can perform the ablation, just ablate the mucosa, that's all. So we are seeking to ARMS procedure from, I'm sorry, anti-reflux mucosa ablation from mucosectomy. Okay. So this is a key point of the ARMA procedure. Like this, so we are trying to preserve some untouched mucosa at the esophagogastric junction in order to make a smooth passage of the food. Anyway, so top column demonstrate the change left to right, the ARMS procedure. And then bottom, you can see a change of the caldera as by the ARMA procedure, left to right. So not a big complication, but anyway, so 5% bleeding and the 12% stenosis happen, but endoscopically controlled. So symptom score improved nicely, and then even 2 years later, it keeps effectiveness. Of course, most important, the impedance pH study improved after this procedure, and it's a quite I think quite interesting. This procedure is effective for reflux hypersensitivity. So far, we have three meta-analyses and a systematic review with meta-analyses. And the three of them, one paper from Spain and one paper from a US Cleveland Clinic, and the other one from Taiwan. And all these three systematic review concluded ARMS-ARMA procedure is a safe and effective procedure. So anyway, so this procedure is a very simple and also cheap procedure to control the reflux disease. But contraction level has a variation. So in order to improve this point, we are starting the anti-reflux mucosal that is demonstrated yesterday. Okay, so technically simple one is using the prong clip. So like yesterday's demonstration, we catch one side, and then bring it to the other side, and then point is catch the bottom of ulceration, not the mucosa to mucosa. When we do it in a mucosa to mucosa, it makes the dead space underneath the approximated mucosa. In order to avoid that, we approximate the tissue mucosa to submucosa or muscle. Then we repeat the procedure. It depends on the size of the mucosal defect. We repeat the procedure, catch the bottom, and then make the junction tight. Okay? And then so we make a very tight junction. So, and then once again, the clip dancing sign. Okay. So this is 4 different cases. So top is a before procedure and the bottom is after procedure. Junction became tight, so it's a good result. And another technical tips is, as I demonstrated yesterday, we place a bilateral counter mucosal incision for decompression of the approximation. So just inject and cut the mucosa, both sides. Okay. We can do this before procedure or after procedure, whenever you want. But after introduction of decompression method, so approximation getting better and better. So now we are mostly focusing on the suture closure. So like this, so using this one is our suture out from Olympus. We can catch the mucosa and muscle layer together. So we can place a more robust, more tough anti-reflux cuff, we can make it. Okay, catch the tail and push the needle, and then, yes, step by step. And the point is when we place a suture again, so not a mucosa to mucosa, mucosa to bottom. At this moment, I'm not sure we are catching the muscle or not, but superficial muscle layer may be involved. And this is the other side, other end. Okay, like this. So we have already placed a counter mucosal incision bilaterally. Then, so center, at the center, mucosal approximation with a free of tension. Okay, this is the completion of the P procedure. Okay, so this is a similar cases. We can catch the mucosa, not only mucosa, callus ring muscle as well. Anyway, so this is a similar case. So I'd like to summarize my presentation. Mechanism of anti-reflux mucosal intervention is a mucosal resection. By the mucosal resection, we can expose the submucosal tissue, which may attach each other in its healing process. And then second point, how to choose the RMX. It depends on the case. If, of course, it looks, when we observe the junction, it looks easy to close using the suture device, so we can challenge. So if it looks difficult, or finally, it's difficult to close the defect, then we can switch to ablation. So that is current strategy for reflux disease. Thank you very much for your attention. This is, if you want to check the technique more, so you can access to the YouTube channel. And then, so this September 5th and 6th, we have a JGS International in Japan, all English speaking. So if you are interested in, at that time, we also have a live demonstrations. So if you are interested in, please join us. Thank you very much for your attention.
Do we have time to question?
Yeah, we can go ahead.
Professor, the two technical issues, how to bend the scope tip and make it near to the cardia. It is sometimes impossible with the normal scope. How to bend the tip of the...
Okay.
And number two, how
No. First question. So how to keep the bending? So particularly when we insert some instrument in a working channel, the endoscopy up angle is not enough. We cannot approach to the gastric cardia. At that time, so we use angle booster. So yesterday, we demonstrated the technique in the live demo. So angle booster, I don't talk about the angle booster, but we have already published, so please check it. So very simple and effective way.
Okay, and how do you take the needle, that stitching needle to the channel or to the fundus? How do you pass the needle?
You mean depth of needle?
Needle, how do you pass that needle from mouth to the stomach?
How to bring the needle mouth to stomach? It's we catch the thread, not the needle, and then so catch the thread and then keeps the needle in a tip of the needle is kept in a cap, front cap, and then under visual control, we carefully, slowly introduce to the stomach.
Thank you.
Professor
Inouye, thank you so much for a wonderful lecture. I just wanted to know about the ablation settings. Which setting you think will be perfect for ARMA?
So your question is ablation? Yes.
Yeah, a setting, proper RB setting for the cautery setting.
Cautery setting, nothing special. It's an APC. I forgot the energy setting, but regular APC. We can ablate the mucosa, and then when we repeat ablation, the APC, then we can see the surface of the muscle fiber. Then we stop it. So I remember when we apply the APC, we keep a very high voltage, 80 watt or 100 watt. So it's a very high voltage. So voltage is a very low. It's ablation. It becomes a very superficial. So it didn't work. So it's better. Doesn't work. So it's better to keep the high voltage, 80 watt or 100 watt, and the effect. I forgot it. 3 or 5 or some high efficacy. Yeah.
Professor Inouye. Yeah, this here on the side, yes.
Yeah.
Now, very nice talk. And I had a question. We are not sure about Hill's grade 4 valves or hiatal hernias, whether we should do this or not. What's your thought on which patients should we do arms and which patients should we not do ARMA in?
Yeah, thank you very much. So you are talking about the indication.
Yes.
Of this procedure. Of course, the patient has a big hiatal hernia, so of course a surgical repair is much better than this procedure. But of course, 70% of the GERD patient has a NERD, so non-erosive esophagitis. So most of the NERD patient has no hiatal hernia. So most of them, so 70% of the GERD patient can be treated by this procedure, I think. And the another point is the before procedure, in our institute, we routinely perform the 24-hour pH impedance. So, so we have to exclude the patient of a functional heartburn. So they are not a reflux disease. So in order to exclude them from indication, we perform the pH impedance.
Professor, so HEAL grade 1 and 2 is fine for endoscopy therapy. What about HEAL 3?
Sorry,
Yeah. What about HEAL 3? Can you do it endoscopic therapy? Arms or arma? Hiatus?
Hills 3.
Hills 3. Hills 3. Yes, it depends on the case. So Hills classification, of course, you know, the grade 1 is a normal. Grade 2 is the some flattening of the flap valve. And the grade 3 is the flattening of the flap valve and the opening of the junction. So they can be treated. So, but grade 4, the hernia size combination with a sliding hernia, and then particularly more than 3 centimeter. So grade 4 should be treated by laparoscopic surgery, I think.
Thank you very much,
Sir,
Dr.
one
Haruhi.
question.
I'm
One
sorry,
question.
the case is ready over there. So they are asking us to switch to the hospital.
Thank you very
You
much.
can have your question with Dr. Haruhiro personally. I apologize for interrupting the question, but we have been instructed to start the live case because they are all ready with the case. So we switch. I thank all the chairpersons here for doing us the honor of chairing the first session, and we switch to the live endoscopy relay from Reliance Hospital. Our team is ready with the case. As moderators, I would like to call upon Dr. Naveen Pulavarapu, Dr. Sandeep Kaloke, Dr. Rajesh Dharamsi, Dr. Mrudul Dharod, Dr. Praveen Rathi. May I request you all to please come up on stage and be seated in the center. We can switch to the case as the case will be presented.
मैं बोलती हूँ
Dr. Swara,
Our
yeah,
case
please.
today is a 48-year-old male post-cholecystectomy. He developed right upper contract pain, vomiting, and nausea for the last 2 weeks. A sonography revealed proximal CVD calculus around 11 millimeters with IHBRD. Multiple ERCPs were done outside, but they failed to remove the stone, and a CBD stenting was done. This is a fluoroscopy image for the same. The patient is now planned for ERCP stone extraction and fragmented stent removal. Over to you, Dr. Tanta.
Dr. Marcel Tantau, your live.
Yes, hello. Thank you very much. And again, I'm here. And we have an interesting case here. If you see on X-ray, we have a stone into the intrahepatic duct at the hilum. And below that, we have a stenosis. So our intention now is to see what kind of stenosis. So in this case, also, it's very important to have spyglass, to have a cholangioscopy. Okay, you have different spines, different cholangioscopies now on the market to see what kind of stenosis, because she's 65 years old patient. If it's a neoplastic stenosis, then you will have to take biopsies and to see. Maybe it's a benign stenosis after cholecystectomy, but it's a classical cholecystectomy because we don't see clips. So in this case, it's very, very important to see what kind of stenosis you are dealing with. So in this case, cholangioscopy is mandatory. So we will perform a small we will enlarge a little bit the sphincterotomy now, just to have more space, a little bit more. Yes. Yes. Okay, now it's okay. Now we will put a spyglass on the guide wire. It's better to have large access to the biliary tree now. She had a stent before, but the stent was spontaneously leaving. So now we will go with the spy to see what kind of stenosis. If it's benign, we will dilate it, and then we will do.
Could it be a ischemic stricture, sir? I'm Dr. Raj.
Yes, it can be anything. So we need.
We have to see
because
inside.
it can be after cholecystectomy. It's a classical one because you don't see clips, or it can be a tumor.
Yes, because it's 65.
It's 65, but in this case, cholangioscopy is mandatory. It's not a. It's a must. Because you cannot dilate anything, and you cannot extract the stone before you know what you are dealing with. Of course, if it's a benign stenosis, then you can dilate, and we can extract laser and extract the stone, and maybe she will be treated as a benign stenosis with
metal
multiple
stent,
metal stent, metal stent, completely covered metal stent. This will be okay. So in this case, it's very important now. It's very didactic to see the importance of the cholangioscopy. In my unit, normally up to 10% of ERCPs we need cholangioscopy.
Yeah, nowadays, it is mandatory to have cholangioscopy. You cannot do ERCP without cholangioscopy.
Can I have the? Yes. Yes, in India, the nurses are doing a lot of things.
Yeah, we have assisted cholangioscope.
I like to do it by myself.
Okay.
And in Romania and in Europe, we don't have so much power work as here. So we have to...
We are lucky to have this.
Yes, you are very lucky. So now we are in a common bile where I have the pump. Here is the pump. So now we can see the common bile. We are...
You always go over the wire?
Now it's easier. No. In this case, with a big sphincterotomy, you can go without the wire. So now we have to remove the contrast medium, which is not a very good... we can... we see the...
Yeah, you have the stone, yeah.
And what is the stenosis?
It looks very smooth, sir.
Yes,
it looks very
it's
smooth.
A benign stenosis after cholecystectomy.
Maybe fibrosis, a lot of fibrosis.
Yes. It's not a big thing.
Yes.
So we will examine very nicely. I think we can get rid of the guide wire just to be more freely to see. I'm continuing washing. So this is maybe the cystic duct. Yeah, scope. Yeah, I think here is some. Here is the stenotic part.
There is no mass or there is no abnormal vessel.
Yeah, so it's a benign stenosis.
Yeah, it looks benign.
This is very important to know. Yeah, here is the.
Some nodularity is there.
What to see a little bit what is it. Yeah, maybe it's from, you see?
Yeah, there are nodules.
Maybe it's from the suturing of the surgeons. So it's, but we can take this.
You can take biopsy.
Or maybe we can take with a snare. If you have a small snare, we can take this part. But it's clearly a benign stenosis. Okay, so I think now not to have too much blood, we will go to crush the stone because this is the stone.
This doesn't require dilatation also, sir.
Yeah.
Does it require dilatation? Because the scope is going very easily.
Very easily, but we will crack, this is...
Laser?
No, laser.
Yeah, laser.
Laser to crush the stone. and then we will crush the stone, and we will extract, and then we will remove that.
Okay. So no biopsy or
no, I will take with a
we will
snare.
take.
With
Okay,
a
you will
snare.
take with the snare.
Because we can take a little bit more.
Okay.
So you have a snare for
which
this
snare?
spy?
Yeah, we have the spy snare.
If not, biopsies. Yes, thank you. So, as you see, this is very important for this cholangioscopies now. You can maneuver by yourself. You can have also assistance, but
we are more comfortable with assistance. We usually don't do single-handed in our setup. Yeah, because
I am doing by myself all the time.
that's
Sorry.
very good.
So now we are with the laser. Sometimes the fiber is not going very easily. So don't force, because you can break the laser. And what is very important, the laser can be very dangerous for the eyes. It's not going out, so I have to go out with
yeah, you have to come out and then take the laser out in the channel. And
yeah, now I am with the laser outside, yes. Okay, and now we can go with a cholangioscope. Oops, sorry. So we are now back in business.
maybe due to the angulation, the laser fiber sometimes don't come out.
Yeah, you see now I have the laser inside. So we have here the stenosis. No, this is the papilla. So we advance now.
Maybe we have gone in another duct.
No, here is the stenosis. And here, now we have the stent. The stone, sorry. So we have here the laser, and here is the stone. So the problem with the, okay, and now we can fire. Okay, it's
we are using the thulium laser.
Thulium laser, but you see it's very nice breaking
Very
the
nice, yeah.
And
Professor, what are the
yes.
tricks? Where should you give laser? How do you break the stone? Can you tell us the tricks?
Yes, the problem is with the laser, you need to point very precisely. With the electrohydraulic, you can be around. Yeah, just wash. The problem is that now we have a lot of debris. We need to wash. Yes. Maybe.
Yeah, we have to come little bit.
Yes, as the lens which got, okay, now it's okay. Okay, and now we see the stone. You see already we break. So with the laser, you have to point very precisely. You see here, just the stone is already breaking. It's very easily, you see, it's very nice. So in these cases, even for a low budget, this is cost effective, because if you want to do it with mechanical lithotripsy, you will have a lot of time, you will use a lot of Dormia baskets, so it's cheaper to break the stone with the laser, a big stone like this, and you need to point it precisely, you see here, and now I'm inside.
Professor
We will need
Tantau,
to have some-
we'll just
yes.
switch to Dr. Chris Core and come back to you.
I cannot hear you very well.
We are switching and coming back.
Okay,
Thank you.
okay, thank you.
Next case for.
Our next case is a 41-year-old male. He had a history of acute necrotizing pancreatitis 6 weeks ago. He had abdominal pain for the last 1 week. An MRCP showed a large walled off necrosis replacing the body and the tail of pancreas, and US confirmed the same. This is an MRCP image. Over to you, Dr. Chris Kaur.
Dr. Chris Kaur, you are live.
Good morning. Welcome to.
Good morning.
Good morning from the Sir H.N. Reliance Foundation Hospital. Again, warm thanks to Dr. Medio and his wonderful team here in the room. I'm struggling to remember all our names. Of course, you know, Super Sajad is here right next to me. Bhupesh also, and Dr. Dr. Nikhil, Miss Vanita, okay, and Dr. Damini. Thank you, and Bhakti Yanis. Thank you. I really do need your help in many ways. Okay, so here we have our walled-off necrosis, and you can see, you saw the dimensions. It was measured maximally at about 8 centimeters on the MR. It looks a little bit smaller. The maximum dimensions here about 6 centimeters, and you can see that, you know, on the if we just scan around, it's about 50% necrotic, but still quite a lot of fluid in there. And the principles of drainage would be, first of all, if it's, it needs, you know, from the Atlanta recommendation, symptomatic certainly. So this patient is symptomatic, and most are going to be symptomatic and it will need drainage. That's probably the first principle. Secondly, when you look at this, you know, or when you look at the imaging, you want to look around for pseudoaneurysm or any vessels at the posterior aspect of the collection, because when this drains and it collapses down, the end of your wall, of your stent, of your lamps is going to be impinging on that, and that is a risk factor for bleeding. So I did a quick scan earlier. There's nothing beyond it. There's nothing definitely in it that's vascular, so we're good to go. And the other principle that we need to talk about also is the thickness of the wall between the stomach and the collection. You want that to be significantly less than the saddle length of the stent. Here we measured about 6 millimeters, and sometimes with one, you know, that distance can be greater. Now, when you are choosing the stent, the diameter of the wand is very important, because you know that these stents shorten a lot, you know, from the undeployed state, and you need a runway of about 3 to 3.5x the diameter of the stent. So we're going to use a 20 millimeter by 10 millimeter axios. So we'll need about 6 centimeters forward kind of runway for this to open up nicely. And this is something that we have to be very, you know, clear about.
True, true.
So let's look at our lesion now. And here we have it right in front of us. And I think this probably looks like a pretty good site, and I just to do the drainage. Now, are there any questions from the audience while we get ourselves loaded up?
Hi, Professor. This is Daveen here from the audience here.
Looks nice. No vessels in the way. I'm going to take off the rubber band and.
So, how often what would be your protocol for necrosectomy once you've done this drainage?
Okay.
Because there's significant debris in this.
Yes.
So how would you go about doing that?
For me, it would be clinical. Fever, basically all the SIRS parameters. If that settles down nicely after drainage within the first 24 hours, then that may be all you need to do.
Right.
And I guess you are talking about, you know, whether we should be doing a DEN. Do we do it straight away? Usually no, because half of them will not need, or more will not need an endoscopic necrosectomy. Exactly, so any further intervention. And then we would do the next imaging about the 2-week mark.
Okay.
Yeah, is that what you would do as well?
Yeah. So we would do on-demand.
We generally, so on-demand meaning clinical assessment, right? Yeah. So Sajahad is backloading a guide wire into the, okay, we just need to push this in a little bit. I just need to get off the, okay.
Sometimes the angulation causes that.
That's right. So tip down, and then we, okay. And then we just want to have this facing sort of the, that lock facing towards me. Okay. So we're getting ourselves organized now. Thank you, Sajahad. Okay.
I think with Axios deployment, it's very important that you are comfortable with the device.
Yeah, you bet, you bet. Because, you know, all the steps are very, very important and we don't want to shortcut anything. So the scope has slipped in a little bit
And to readjust and
yeah,
refocus.
exactly.
One question.
Yes.
Yeah, like why do we need a guide wire into a hot access? Usually it is done
Well,
without
you
a
don't.
guide wire.
You can do it without. You can certainly do it without. And what I asked for, why the reason why I asked for it is because a guide wire is really an important safety sort of kind of like a backup. Why? Because if you mal-deploy the stent, that is your lifeline. Otherwise, the patient may have to go to surgery. With a guide wire inside the collection, you have the option of pulling that stent out. If it's like a type 2, for example, you can pull it out, leave it in the stomach over the wire, and then deploy another stent through the wire in exactly the same position. And this time, hopefully, you know, with all the flanges in the right place. Huh? Okay, here we are again.
So how much necrosis would you say that definitely I'm not going to touch the wand through stent placement?
Sorry, I couldn't quite
hear you.
Yeah,
Can
can you say that a bit louder, please?
How much necrosis in the collection that you say that I'm not definitely not going to touch the hot axis, or I wouldn't do this gastroscopy? How much necrosis or solid debris?
Well, you know, actually, that's a good question. You know, the actual FDA approval in the US is given for pseudocyst, not walled-off necrosis. So the short answer is I'm happy to use it just for simple pseudocyst with no necrosis inside because it's so quick. I mean, you can be in and out, you know, if you don't need to do any discussion within like 5 minutes or you know, thereabouts, right? So it's a very quick procedure, and also safety, I think, potentially is higher because once you have these exchanges, that's when trouble occurs and when things can go wrong.
So typically, I say if there's a collection which has more than 50%, I would not consider draining it endoscopically because then it becomes difficult. You know, the stent gets clogged very frequently, and then the patient comes back with fever. So,
We're actually happy to use it because you know, and even though you know those with a lot of solid material in there. Okay, pass. Okay, okay. I mean, ask this. Get going.
Yeah, we can keep on discussing once that is. The
Yeah, we
procedure is
can.
on.
We can. Okay.
Okay,
Okay, here we go. Okay, so let's just quick look at the.
Yeah, quick Doppler to make sure there are no vessels in
Yep.
the way.
Okay, now I'm seeing a signal kind of little bit there. Maybe we can just swing off this side a
This
little
is
bit.
good.
Yeah, this looks good. Okay.
This looks good.
Yeah, this looks good. Now maybe just pull back a little. Okay,
Yeah.
excellent. And so, Vanita, can you just pull back the scope a little bit for me?
Yeah, just support the
Excellent.
scope.
Yep. Okay, so AutoCut 100. Gonna just we need to have the scope. Yeah, I'm unlocked now, but our system is not coming out. So let me just, yeah. It's not coming. Yeah, okay, now we are. Okay. Okay, so now we need to adjust again.
Yeah, adjust the scope again. Get the.
So everything has moved a little bit since.
Yeah. Yeah, this is good now.
Yeah,
Can we
so
have
just trying to
Doppler again?
find a
Just
nice,
make sure.
a thin area. Yeah, Doppler again, please.
Yeah.
Okay. Okay, so scope tip up, try to get as much of a perpendicular as you can, and then burn yourself in.
Beautiful.
Okay, good. Okay, so
Smooth.
now we are pushing in as a little bit further because we want that runway. Huh?
Yeah.
Okay, lock here, remove the.
Pushing the guide wire inside. If you can get the fluoro
Right.
signal also, a fluoro small, so you can see the guide wire passing into the collection. Yeah.
Yeah. So that is your safety.
Yeah.
So remember that. Okay, we can deploy now,
Now he's
under
deploying the
EOS
distal
view.
flange. Distal flange.
Very slowly. And it's a little bit stiff at the beginning, and then you will see it, and then we need to adjust. Yeah, we need to adjust inside. Yep, that's right.
Fully in, so I
Yep. Okay. Yeah, so this is an important point because you want it, this is going to spring back. Yeah, we can take the hot off. Yeah. Okay. Yeah, okay.
Now
Yeah, okay. So now we are, okay. Yeah, we need to push it. Yeah, correct, yeah.
So maybe with the sheet you can just jiggle, pull
Yeah,
back.
we're doing that. Yeah.
Now you can see
Yeah.
the distal flange.
Right. So it's coming open. Yeah.
Yeah.
So we want it to be, yeah, you can see it opening on the, yeah,
EUS.
that's good, that's good.
So sometimes this happens with
yes.
the Axios, that it takes
Yeah,
time for the
it
flange
does.
to open up.
So it's important that we don't, yeah. So you want to see that, you can see it both under EUS, okay, now?
Now
Okay,
you can,
all right.
You can pull back.
Okay, and then so we'll pull back a little bit, okay, and tent it here.
Yeah.
Okay, so you can see like that inverted wine glass view, and then we lock that here, turn away a little bit, and then we can start the deployment of the proximal flange intra-channel. Huh? Okay, so slowly we are doing that. And always lean away. Now it's fully deployed. Okay, so I'm going to unlock here. So let's look at endo big view, please. I'm going to lean away a little bit. Okay. And here now I'm going to push this out. Yeah, just withdrawing and push out. Push out a little bit with the sheath. Yeah, this is, wait, hold on. Yeah, we're just unlocking. Yep, sorry. Okay, pushing it, pull back the scope. So a little bit of jiggling here as well. Okay, the point to make is that you have to be away from the, and then you'll see it right. Thank you very much. Okay, so here we are deployed. Let's get a, So now, we can take out the wire because we know we're in the right place. Huh? Yeah, it's okay. I'm just putting a little bit of gas in there. Here we are. So if there were a problem at this point, you can see a lot of fluid coming through. And the patient is intubated, and that's a good safety measure also, because in a large collection, you could have a liter of fluid in the stomach. So you can see it's purulent material. We can get a smell in the room as well. Okay. So thank you to everyone in the room for a nice, smooth deployment. Thank you. So that saddle will open up. Thank you. Thank you very much. Thank you. Thank you.
Dr. Chris?
Okay.
Dr. Chris?
Yes.
So I think from the last 2 days, everybody is talking about the wire. But
I beg your pardon?
Everybody is talking about the wire in the lamp.
Okay.
But I think for the GJ, it should not be used. I think that message is important.
But,
while doing the GJ, you should try to avoid the wire.
No, Rajesh, actually, I have slightly different view that I think if you're going to use it in a GJ, it has its value as well. But you only put the wire in after the internal flange is deployed. If you
that's agree.
Yeah.
That's agree.
And then again, that gives you an element of safety as well. Huh? Yeah, it is a safety net. Yeah.
Yes.
Yeah. So the important is the internal flange has to be deployed so that, and also the pushing of the wire needs to be gentle as well. So you don't, but once the inner flange is in, then you've locked it in position, right? And then you can put a couple of loops in, and then that is your safety in case the external flange goes into the wrong place. Yeah.
Agreed.
Okay,
Thank you, Dr. Chris.
Thank
We'll
you.
just
So
move
I'm
to
just
the next
decompressing
case.
the stomach and we'll be out.
Patient is a 46-year-old male with chronic calcific pancreatitis with pancreatic stone disease and diabetes mellitus. An ERCP was done for his stone disease with a ductal clearance and PD stenting. 2 weeks after this, he developed abdominal pain. An MRCP was done which showed a fragmented stent which was proximally migrated with a stone persistent in the head and tail of pancreas. He underwent 3 sessions of ESWL with 8,000 socks each in each session. He is now planned for ERCP with pancreatic stent removal and ductal clearance. Over to you, Dr. Andrea.
Dr. Andrea Andeloni, your line.
Dr. Andrew, we can't hear you.
Me in this tough case. We have here a pleasant young man with chronic pancreatitis that was previously treated by lithotripsy and placing a plastic stent. But due to the loss of follow-up, the plastic stent migrated inside the pancreatic duct and stayed there for several ages. So the question now is to get into the pancreatic duct and try to retrieve the stent. So the aim of the procedure is stent retrieval and check if other stones are inside. While we were waiting for you, we were able to enter into the pancreatic duct. If you can have a look to the X-ray, we are inside the duct. We are going to inject a little bit of contrast in order to show you the anatomy of the pancreatic duct. You can clearly recognize the stent. You can clearly recognize a dilated duct with a Santorini duct as well. From my point of view, the first 2 centimeters of the pancreatic duct retropapillary are a little bit of stenotic. So before starting anything, I am going to dilate that. Because of course, when you need to retrieve something, you need to be sure to have an exit that can allow the stent to exit.
Number one, which balloon you would prefer? And number two, what will be the size of the balloon? How will you determine which size you will?
Oh, those are 2 very good questions. For this kind of situation, we are going to use, screen please, to use the hurricane balloon. The hurricane balloon, as we were saying yesterday, has made for this tough situation because it can reach a very high pressure in comparison with the CRA. Moreover, it's thin, it's very powerful also to overcome very tight stricture.
And how will you determine which size balloon you use?
So today we decided to go with the 6 millimeter balloon in order to allow a good exit. But since ERCP is a complex procedure, we always have to think about plan B and plan C. So if we are not succeeding with stent removal with usual stuff like snare, we have a good opening to the spyglass.
See, does the upstream duct diameter make you decide that what size of balloon you use? Or you always use 6 millimeter? Because that much space you need to work on.
So depending on the anatomy of the stricture and also on what I have to do, I can choose the diameter. To be honest, 6 millimeter is one of my favorites. So it's very important to check radiologically the 2 markers. Can you give me X-ray for a while? Okay. Can you see the 2 black markers? There is one right inside the pancreatic duct and the other is just outside the scope. So this is a very good position to start dilation, but I want to show you, okay. So, can you start inflating? Look at the X-ray, you will see easily the
you can see
contrast.
the waist,
And there is a little waist.
Little waist.
What do you think?
Yeah, there was a little waist which is getting obliterated,
So, at this moment, we are just at 5 atmosphere. I want you to remember that hurricane balloon can reach 11 atmosphere. So in comparison with CRA that reach the maximum of 6 to 8 atmosphere, you can appreciate the power of this balloon. Okay, so shall we go further with the pressure in order to overcome? Okay, the patient is feeling pain at that moment.
It means basically
we are sorry for the patient, but this means that it's working.
Balloon is working,
Can we have X-ray? Okay.
Switch
So
X again.
I always keep the balloon inflated for a while in order to allow the distension and the dilation.
Dr. Andeloni will just be back with you in some time. We'll just
You want
go
some
to Dr.
Buscopan?
Yamamoto and come back to you.
I cannot.
You want some Buscopan?
No.
Dr. Andaloni will just switch to Dr.
I cannot
Yamamoto and
hear
come back.
We cannot hear you. Yeah. Okay. Okay.
Okay, they have
Okay,
switched.
fine.
Year-old male. He had epigastric pain and bloating for the last 1 month and a history of weight loss for around 13 kgs. He underwent an OGD scopy which showed a large 5 centimeter LST arising from the posterior medial wall of the duodenum extending up to D3 with multiple sessile heads. The base of the polyp went from D2 to D3. The ampulla is separate from the LST. A radial EUS was also done which noted the same and a biopsy of the same showed a tubular adenoma with low-grade dysplasia. The patient is planned for piecemeal EMR. Over to you, Professor Yamamoto.
Dr. Yamamoto, you're live.
The polyp carefully. So I checked that. Then I found that here is a polyp neck, and this is a multiple polyps sitting together, actually. Multiple polyps are sitting together. So I was planning doing ESD, but actually this is multiple polyps, so it's better to do underwater polypectomy rather than ESD. And if there is a wide base polyp remains, then I might do ESD, but otherwise I just do underwater polypectomy one by one. So I will start from this polyp. Here is the neck of the polyp. Here is the neck of the polyp. And polyp is like this. So using underwater technique, you can see the base better, and this scope is a very small caliber scope. So it can go between the polyps, and you can see the base of the polyp. You see? Multiple polyps.
This has a therapeutic channel of 3.2 and outer diameter of 7.5, which is why putting the scope across the polyp head is possible.
So this is a small polyp.
Yeah.
So shall we just cut one by one? Okay, open. Open. And then I will capture this polyp. This is 20 millimeter.
20 millimeter.
Yeah. The round. Open. Maybe this snare is a bit too big for this polyp.
I think this snare is too bigger for this.
Yeah. Open fully. This snare doesn't open properly. Just a moment. Then, yeah. Yeah. I use this snare. I want to reshape. Because before the transmission, I snared it. Then once I use the shape becomes not that. Reshape and then close. Close. Okay, then resect from a bigger one. Where is the bigger head? This is the bigger one. And this is the head. Here is the neck. Here is the neck. Probably this is a good target. A good target. Okay. Okay. Open.
Yeah, so this is the principle of underwater where you are trying to, snare the polyp into the snare. You want to use more and more flushing so that the polyp is entrapped or garlanded into the snare. And you maneuver your scope, which Dr. Yamamoto is showing excellently, and try to reach the base, try to reach the stalk of the polyp.
Here is the stroke.
Slowly close.
Just a moment. So this is the
I think it might come piecemeal because the snare is not completely moving around the polyp. And
yeah,
that's
might be a piecemeal, but
yeah,
it's okay.
but
Okay, let's
nonetheless,
close
slowly.
Okay. Okay, then.
So the endocut settings we are using is effect 3, duration 1 with the interval of 3.
And I use a little bit of coagulation first.
Start with some post coag and then switch
Then
to endocut.
endocut. Okay. Is this resected?
Yeah, I think.
Dr. Yamamoto, we'll just switch to Dr. Tantao and come back to you.
So hello, we just wanted to show the stenosis is benign. Maybe from the cholecystectomy, the surgeon treat a little bit common bile duct here, and we have a small polypoid lesion which is inflammatory. We will show you how to polypectomy inside the common bile duct. Open please the snare. This is a small snare for the spyglass, and you see the polyp. And it's very important to have control with both scopes because you have to maneuver the second one. So, and you see now I have a good position and a little bit to push. It's not very easy.
Yeah, we are using this spyglass retrieval snare, special snare with 286 centimeter and 9 millimeter diameter. Yeah.
Okay. Yes, now close, please.
Yeah, very nicely demonstrating how to catch the.
You see, we have the polyp, and now we need to cut it. You maybe cold cut.
Cold cut, yeah, you can do cold cut with this, yeah.
Please. I think it won't happen because it's in the cystic duct. So you see here, it's the cystic duct which comes from the cystic duct. So it's we need a hot one. It's not only cold. Okay. Maybe we had wires inside.
Yeah.
So then we will see. you see, it's coming from the cystic duct. There is the cystic duct. So the diagnosis of this stenosis is completely benign. The stenosis is not very large. The stone we crushed completely. Yes. Open please a little bit because it's too tight. Open?
Yeah, benign.
So, yes, we'll take a biopsy. Okay. Okay. So you see how we can take a polyp, but it's the cold, maybe some wire inside. That's why it's like this.
Yeah, yeah.
It's a surgical
suture,
wire.
yeah. Maybe some suture inside.
Yes.
So,
we can take
Professor, isn't it stitch granuloma rather than thinking too much about the
I will
pathology?
show you the stone. It's completely
Yeah, you can
crushed.
see the stone is completely crushed and we are going to remove it with the basket. Yeah. Yes, yes.
See the stenosis is large.
Yeah.
It's benign.
It doesn't require any stenting now, yeah.
And maybe it's some wire from the surgeons into the cystic duct. This is coming from the cystic duct.
So it's a stitch
very
granuloma.
nice demonstration
Yeah,
of the
cystic
importance
granuloma.
of. And now we will take some biopsies. So the importance is, you see, I can maneuver with both hands.
Yeah, he's
scope.
doing it himself.
Yes. And this is how we can do it. And we can do completely very complicated things into the common bile duct. So this is a big advantage. Now I try to get out. This is the problem with 1.2 operating channel. It's very difficult to get inside the ducts everything because it's too, yeah. I need to take out the scope and take
Dr.
out
Tanta will switch to Dr.
So
Andaloni
we'll
and
take
come back to
biopsy
you.
and remove the stones.
Yes.
Yeah.
Sanjay, last.
So I have to do like this because we are zooming. No, no, don't move, don't move. I will. We want to show you the snare that we are using. So this is the snare. This is an EMR snare. It has some nice characteristics. One is the shape that is like a duck. The other one is that is very, very flexible. I'm going to show you. Very smooth and flexible. And this will help us a lot in the bile duct. So if you can come now to me, can you come now to me? We are going to load. Okay, here. We can show how to load the snare into the guide wire. So I will keep the guide wire and the snare will stay inside. Okay? So we are going to use the snare like a classical accessory for biliary. This is a clever idea.
Professor, the simplest thing would have been to put a foreign body forceps into the duct and get it out.
A foreign body forceps is not so easy to maneuver inside the pancreatic duct, and especially you can have the help of the guide wire here.
So guide wire always helps, and by the side of guide wire, foreign body forceps can be passed very easily, and it's a very standard procedure.
No, agreed. But the issue is that there was a downstream stricture. We have dilated it, but the snare will go over the guide wire. So the access will be straighter.
Yeah, can you close the snare a little bit? Because there is a waste there.
I think I am in. Are you open? Okay. Yes, yes. So now it's very important to have a look and to try radiologically to understand. Let me check. So you can open. So yes, we need to do one thing at a time. So now we are fully open in the middle of the stent. So just give me 1 second. I will withdraw a little bit in order to try wait a minute, wait a minute. I'm going to tell you. To try to, okay. Can you open a little bit? Okay. Now we are fully open. If you can close slowly, I will follow you. Stop for a while.
Just wait.
Okay. Keep the, okay. So can you close a little bit more? Close a little bit more. Close. Okay, we are not in the area. I need to go slightly higher. So just, I will keep it here. So it's very important here to be patient, to move a little bit, to do this jiggling. I don't know if you can appreciate the movement of the snare inside the bile duct. This is also good to do this, yes, pancreatic duct. And to do this like the radiologists do, you know? So,
Professor, do you think a smaller snare would be better? Is this too large for this?
Well,
we are not getting the right access. The size is fine.
Okay, reopen, open again, open again. This is very flexible, so it will help us doing what I'm doing now. See? Okay, try to close now. See?
Yeah. Excellent.
Did you see that the stent moved a little bit? So we are pretty close to take the stent. Let me check. Do you feel something? So now I'm going to. Yes, yes. Now it's very important that you do what I say, because otherwise 3 people will speak and it will be very, very difficult. So let's go up. X-ray. So we are going slightly higher in order to check. Another idea is to take the guide wire out. Okay, try to close here. I'm pushing. Try to close here until the end. We are, oh. Did you close? Have you got something? No. So one idea could be to remove the wire for a while. Let me do this. Okay, stop. So are you open now? Open. Okay. So we are close to the stent. See, the stent is fully open. Yes. So try to close the stent now. Sorry, wait a minute. It's very important that you cooperate with your colleague. So it's not going. So what we can do now, try to open now. We are nearby here. Open, fully open, okay. Stop there. I'm going to fish like this. It's very important to try to fish like this. See that?
Yeah.
We moved a little bit the stand. Don't close, don't close. We need to do this. See that now the stand is moving. This is a technique that we call the fishing technique. Let's see now if we are in a good position. Try to close now. Tell me if you have anything inside. No. No, no, no. It's going in the right. The other idea is to go there with a Dormia basket.
Dr.
Do you
Endoloni,
like
we'll just go to Dr. Yamamoto and be back with you in a minute.
Yes, yes,
Thank
yes.
you.
I wanted just to show you. So, you know what?
Dr. Yamamoto, you're like.
Okay?
Okay, I have resected. So this is multiple polyps sitting together. So the piecemeal or multiple polypectomy is better strategy for this kind of polyp. And polypectomy, the big problem is the bleeding for this kind of large polyp. So you have to select a good mode for the polypectomy. Anyway, I use Endoscopy Q, and I increase the effect to 4 and the interval 5 to coagulate more before cutting. And cutting duration is 1. Then here is another neck here. So I will resect this polyp. So after checking the neck, I open the snare open.
An open full snare.
Fully open. Okay. Then
So these are the standard steps when you're doing underwater. One is maneuvering, then garlanding your snare across the polyp.
Okay, close.
And then you close the polyp. And while you're closing it, again, you irrigate some water so that to make sure that you have just enough tissue.
Okay.
Now in the duodenum, you have more submucosal plane where you have to be very careful not to go too deep. So now Professor Yamamoto uses the coag followed by an endocut. Yeah.
Okay. And then resected specimen is retrieved to the stomach.
Because this limb scope has a 3.2 millimeter channel, so suction is slightly more powerful than your routine gastroscopes. And I think you'll just park it in the stomach and go in again and complete the piecemeal dissection.
Yes.
So that's the advantage of these newer scopes. You get the therapeutic channel, you can use it to its full utilization and optimize its efficiency. So again, once you enter, first thing you have to check is the hemostasis. So you want to go to the base of the polyp that you resected and identify which are the potential or the bleeding vessels in that area.
Yeah. And if there is a bleeding, then I coagulate with the coagulation forceps. But
do you change to another mode like the RDI? Do you have another mode in Fuji?
Yes.
Yes. So can we switch to the ACI mode and just demonstrate how to use the ACI mode in bleeding vessels while doing polypectomy? So
Yes.
here you can see more amber colored vessels, and the blood here becomes more
blood is here.
Yeah, orangish, more amber colored. So just
So
more
where-
pleasant to the eye, not straining like when you see in your white light imaging.
So this is the blood vessel bleeding here. So
keeping his scope calm, stable, focused on the vessel, causing a pressure tamponade on the vessel, and then thereby using coagulation forceps. Very beautifully demonstrated.
thank you. Thank you for good explanation.
So often what happens is when people are doing the underwater, the moment you see bleed, you start to inflate and give gas, and you switch to a conventional method of doing EMR or polypectomy. But here, Professor Yamamoto is staying with his principle. He wants to stay underwater and using coagulation with the help of ACI. Very
Yes,
selectively
good.
coagulating the vessel.
Yes, because the duodenal wall is thin, so you have to coagulate only selectively. Okay, close. The blood vessel is coagulated, but not the muscle layer too much.
So you hold the vessel, you retract the vessel into your channel, and then coagulate.
Yes, exactly. I placed a cap, which is a tapered one. The opening is only 4 millimeter in diameter. This is a good cap for the ESD for the pocket creation method. But maybe this is not an adequate one for snaring. So I am considering changing the cap. Shall I change the cap? It probably.
So we can switch to another OT while Professor Yamamoto will switch to a more conventional EMR cap.
Before we make the switch, I would like to switch the moderators here. So thank you, moderators, for moderating the first session. And I would like to invite the next set of moderators. Dr. Eli Ogutu, Dr. Sandeep Patil, Dr. Sharan Mali Patil, Dr. Devinder Singh, Dr. Chintan Patel, Dr. Manoj Vyavhare, and Dr. Amit Gupte. May I request you all to please come up on stage and now moderate the other cases. Thank you so much, sir.
No.
Dr. Antononi, you are live.
So where is for you? That is the biliary.
Dr. Antononi, you are live.
Yes, we are trying to reach again the pancreatic duct. And even if we did dilation, we are struggling now coming back to the pancreatic duct. So you have to give me 1 second. That is the biliary. See that? So we are trying to understand where is the pancreatic. Now, that is not. Okay, let's do here. And do a little bit. Contrast? Contrast. Okay. So it seems we are close.
Close, yeah.
Don't push me. Okay. Okay.
Yeah.
So although we did the dilation, we still have some problem. Okay. So let's see if we are able now to go inside. Probably
you are there.
We have the stent that we have moved.
Yeah, that is causing problem, yeah.
Yes. I cannot go in there with the... So this could be also a good thing because it means that we were able to move the stent. So now, are you okay? A little bit more up. We are going to take the Dormia basket, guide wired, in order to try to catch. You want me to go higher? Okay, it's okay. So we are going to...
Dr. Donnie, you'll try Dormia basket now?
Place the Dormia basket that hopefully will help us to catch the stent. I have the feeling that the stent is, let's say, not anymore
fixed.
So we have moved. This is a very good sign. And it seems that it's bended as well. So this could be good as well, because although he won't allow us to move easily, he can give us much more to grasp. And hopefully with the guide-wired Dormia basket, we will be able to catch.
Dr. Andoloni will just go to the next case and come back to you.
Oh, yes, whenever you want.
Thank you.
Our next case is a 50-year-old male. He's been having abdominal pain for the last 1 week. A sonography was done which showed a dilated CVD with IHPR. An MRCP was done which showed multiple intrahepatic ductal calculi. An ERCP was attempted outside which again confirmed the multiple intrahepatic ductal calculi. However, there was failure to remove the stone and a 7-French stent was placed and the patient was referred here for further management. Over to you, Dr. Surinder Rana, planned for ERCP and SPY laser lithotripsy.
Dr. Surinder Rana and Dr. Ravindra, you are live.
Good morning, everyone. On screen visible and I'm audible.
Sir.
So as mentioned, this is a patient who has got multiple CBD stones and gallstones, and even on a fluoroscopy, you can see that these are calcified stones clearly visible on fluoroscopy. So we have cannulated the common bile duct, taken a wire deep, and then we are just getting ready to do a cholangiogram. A small sphincterotomy has been done, and then we look at the stones. Few of the stones looks to be quite bigger in size even on fluoroscopy as they are calcified. So we'll take first cholangiogram.
So Surinder, if we see a calcified stone even without a cholangiogram, I think we have to be careful because these are all very hard stones.
Very hard stones, yeah. So Sajad is there assisting me. So we are going deep. Yeah. And so we have gone into the left system. And we are just injecting contrast. So you can see there are multiple intrahepatic stones also there. So Dr. Ravindra, what would be the plan now? You see stones are quite deep.
No, I think we have right anterior duct stones also.
Yeah, so
which are,
I'm just filling up the lower CBD. So you can see there is little tapering at the lower end of the CBD also.
I think we should plan a balloon sphincteroplasty. If needed space, we'll do a sphincterotomy.
Yeah. But yeah, so partial sphincterotomy has already been done. So I think we can do a large balloon papillary dilatation. Yeah, so taken the wire up, should exchange. But I think these are quite difficult stones to take out, especially the ones which are higher up.
Surinder, best of luck. Probably these are the worst stones to have. Radio opaque square stones. My question is,
as well as intrahepatic stones.
So you must have troubled a lot of people in the past, I think.
No. I have a very easy way out of putting a stent and coming back. So we'll just see how easily we can do, and the tough ones we'll see at later stage how to take them out.
Yeah, and I just have one question. What do you do for those intrahepatic stones? Just leave them?
Yeah, I think it's very, very difficult. We may try taking up SPY up, but I really doubt our SPY will reach there.
Yeah.
So we might have to study the cross-sectional anatomy of the liver, what's happening to the upper duct.
Dr. Surinder?
Yeah.
I think this is one of the relative contraindication to do the large papillary dilatation. There is a stricture at the lower end. You produce more pain.
Yeah, I think, Dr. Sanjay, for that, what happens is that could be because of the stone causing underfilling of the bile duct. So what we do is we inflate the balloon as Sajad has done, and we look at the waist. If after 75% of inflation, the waist is still there, then I will not do balloon dilatation. But here you can see on fluoroscopy, it is done very well. There was no waist at even 50% inflation. So that is one thing which should be kept while doing a large papillary balloon dilatation, because sometimes you can have unexpected strictures there which are not documented on normal cholangiogram. So you inflate, putting a combination of contrast and saline, and inflate the balloon and look at the waist. So if you have inflated 75% and waist is still there, you should really suspect that there is a stricture which was probably missed. So that's a good thing to do. Many of us do.
Is it a hypertrophic papilla or it is adenoma?
No, I think this is because of the stent which was placed previously. So that stent has caused that stent-induced changes at papilla. So Sajad has done inflation, so we do it for about 60 seconds.
Professor Rana, though, do you think with the harder stones, a higher wattage laser will be of more benefit when you're doing cholangioscopy? Because most of us, when you use laser, have up to 30-watt lasers.
Sorry,
So
I
do you
couldn't hear
think,
you. Can you please repeat your question?
No, I meant most of us, when we use lasers, these are 30-watt lasers.
Yeah.
So they have relatively less power than the newer 100-watt lasers, which can be used for tissue, ablation and destruction. So do you feel like the harder stones will benefit more with the more wattage, more powerful laser?
I think personally such
Do you have any personal experience here?
Yeah, personally such calcified stones are very, very difficult to break. So,
Yeah.
if we would have our success rate with such dense stones, which are visible on fluoroscopy with EHL or laser is anywhere between 30 to 40%. So majority of them, it's very, very difficult to break. And I agree with you that our laser settings have low energy. But then you have newer lasers which are coming up, which have the various modes like dusting, fragmentation, combination. So I think that maybe those modes, when used in combination, may help us achieve better results. So laser is still in evolution, and I think the best of laser is yet to come.
No, Surinder, I think the new thulium laser and the present lasers also, if we use it for a longer duration, I think we can all break them.
Yeah, but the problem is longer duration. Obviously, there is problem of thermal injury also being there if you keep on using it for a longer time. So those
Surinder.
issues are there. So
Yeah. Surinder, any preference between laser and EHL for these hard stones?
Sorry, I couldn't get you.
Laser
So
and
any preference
laser
between
and
laser
EHL.
and for these hard stones I'm talking about?
I couldn't get the question.
No, no, laser and EHL.
No.
Is there any difference? See,
Yeah, laser and EHL, I think the studies have shown that both are equally effective. Maybe laser would be probably marginally effective. Personally, I think both are equally effective. The only thing is that EHL is, yeah. So there, yeah.
I think you
Sajad is
managed to
pointing
remove
out
the
there are cystic
stone.
duct stones also. So what happens is with EHL, you can break the stones. The machine is not so cumbersome, and it's easily doable. For laser, you have to do a lot of precautions, and the OT should be properly wearing goggles and all those precautions. Along with that, EHL is little costly on for patient basis. EHL will be little expensive. So that's I think the difference. But more or less, I feel that both of them are equally good in breaking the stones. That's what the literature also shows. Let's go. So we are just trying to go into that right anterior system and see if we can remove CBD. I think we have more or less cleared. This is going into cystic duct. You want me to go into there? Yeah.
I think effectivity wise both are same, but only thing is by cost wise laser is less cheaper, because the same laser we can use it for 10 to 15 procedures, because 270 centimeters we can go on using. But whereas this will go in 2 or 3 cases if we reuse. That's the difference.
But I think if you use EHL judiciously, taking care of probe also, maybe you can use probe for at least 3 or 4 cases. Yeah, sure. It's difficult. Yeah. Very nice. Very nice.
I think
Sajad is a master.
Yeah. Yes, we have gone to that duct which is there. The only thing is,
Sajad is confident we'll be able to take it out, and I believe him.
Yeah.
Distance.
the lower duct is smaller.
I think what we'll do is we'll dilate that segment of the intrahepatic radicle. You want me to go up? Yeah.
But really, it's important to remove that stone. I think that stone has become part of liver. Just leave it. It's too peripheral. I don't know whether MRCP was done, whether it was obstructing. And benign obstruction usually with stone should in intrahepatic segment should not cause too much of a problem.
I agree with you. But Sajad is saying that we should make one attempt. So let's see if we are successful.
You have to. You don't have a choice. If Sajad says, we have to do it.
How safe would be the dilatation at that proximal level?
Nilay, the plan is that segmental duct, we want to dilate and then we see once. If it doesn't happen, we leave it.
I think you are in a different duct, by the side of that stone duct. That is what I think.
Okay.
You are not in the same duct.
Right.
Dr. Surinder will just
think the
switch
duct
to
is
Dr.
also
Yamamoto
narrow
and come back to
distally.
you.
Yeah, personally, I would have not done anything. I would have given up at this point, but I think I'll go by the hunch of Sajad. So we'll just see where we are. Before dilating, we'll see which duct it is also. Can I have fluoro, please?
Dr. Surinder will just switch to Dr. Yamamoto and come back to you.
Sure.
Yeah,
Why?
thank you.
Can I watch?
Dr. Yamamoto, you're live.
Okay. So this is the resected specimen, and leaving this resected one in the stomach. Then I go again. So it's important to control the bleeding even with snaring. So this is the resected area. Now still has a lot of polyps, but less than before. So let's decide which one we should take. Shall we take this one? Yeah, but okay, let's see. Here is the normal area. So that means this is the okay. Open. Oh, sorry. Slowly open. Okay, and yes.
Professor,
Okay,
what's the
close
cautery setting
slowly.
for this?
Close slowly. Okay.
Gaurav can't hear you properly. Is it dry cut? Is it pure cut? Or is it endo cut?
But however, this patient is a CKD. I think they must have told in the history he is on medical treatment for his.
So higher chances of bleeding. CKDs
Yes,
have higher chances of
yes.
bleeding.
So
Yeah.
which is why the effect has been increased to 4. Now the trade-off is that there is a risk of more thermal injury, more delayed, muscle injury or a perforation. So that's what we were discussing, whether should we really compromise on those facts. So after the resection, I think complete water seal closure is more important rather than just resecting. So Professor Yamamoto has
Yes,
that in his mind.
Yeah, I will close the defect.
Okay. But otherwise, you can use also dry cut, right?
Yeah.
For underwater EMR.
What is your experience with dry cut?
Babu?
Do you often use dry cut with underwater?
Yes. Dry cut, you mean the dry cut for the ESD or?
EMR, underwater.
Underwater EMR. No, I don't use. I just use endocut.
Professor
why-
Yamamoto,
why
you
are you
noticed
asking
that you have changed the cap as well.
Yeah.
Is this, what, can you talk more about the cap that you're using? I think there is a sort of exit at 12 o'clock for fluid to come out, right?
Yes, that's right. This is a cap made by Fujifilm company, and it's specifically for this TP scope. And window at the 12 o'clock is for the drainage of the bubble or fluid. Okay, slowly close. Okay, looks good. Okay, then and then go to the. It doesn't work well. Okay.
Dr. Yamamoto will just switch to Dr. Surinder Rana and come back to you. Dr. Surinder Rana, you're live.
Yeah, so now you can see that we have dilated that segment of the intrahepatic radical with, it's what, 8 mm? 8 mm hurricane. And we'll just now make an attempt to remove the stones. So Nilay, what's your hunch now? Will it come out?
I still think it will not.
It will not, okay.
But I can't fight with you guys, especially you have Sajad on your side. So
No, I have Sajad, I have Ravindra, and I have Sanjay also with me. So it's a heavyweight team now here.
True. So do you think the duct downstream is pretty narrow, right? So if I can see correctly. Okay.
वायर थोड़ा सा करना पड़ेगा. Different duct लग रहा है. Different duct लग रहा है.
Yes, yes. I think भी small करके थोड़ा balloons. Now I think you can see small fragment has come out. Huh?
The fluoro look was slightly deceptive, it feels. You know, they are all soft stones, not as hard as it seems.
छोटा कर दिया तो हो जाएगा. Yes.
Let's hope it comes out.
It's a square stone.
It's difficult.
I think we are finding it little difficult. It's a
yeah.
square stone.
I just think that maybe a spy, if you want to get it up there and break it down, because the duct
is a little bigger
seems very
stone, I
narrow.
feel.
No, it's a
So I don't know if it'll even
square
come out
stone.
even if you
Yeah,
get
it's a-
It's
access
not
to
a
it.
round or an oval stone.
Yeah.
I think a irregular square stone.
So I'm giving a sustained pressure to see whether it just pops down. Any trick, Nilay?
Can we do an occlusion cholangiogram here?
my base trick is leave it. Or else you can put a spy and see whether you are in the same duct, whether you can.
Yeah, I think we are in the same duct. It's only the size of the stone which is.
Yeah. It's square and it is hard, I think. Yeah.
Yeah, square irregular stone, I think.
And it is stuck. See, the very fact that it is in the IHBR and not in the, it's in the peripheral duct, not in the central duct, meaning it is impacted there. So
Yeah,
if
I
you
agree.
really want to do something, just go with a spy
I don't
over
think
the
so,
wire.
that it'll come.
and
It
see
will not
what-
come, Nilay. I think I agree with you.
Yeah.
So now what we'll do is we'll just put a
Put a
stent
stent
and
here.
make
Yeah,
an
yeah.
attempt. Let's look at exchange.
I think Neelai's hunch is Been found right now.
So we'll just put a stent. We have cleared the lower CVD. This we'll see in a later setting if we can take it out.
True. Sometimes the stent do make wonders, and then stone can get disinfected or
the stent. Yeah.
Yeah, yeah.
Dr. Surinder Rana will just switch to the other room.
Yeah, thank you. Thank you, everyone.
Dr. Andaloni, you are live.
Yes, so we were able to remove, let's say, the stent, but part of the stent. As you can see from endoscopy picture, you can see here the pieces of the stent that we have taken out because the stent has broken. So there is still a small piece floating inside the pancreatic duct, and we are trying to retrieve this as well. Are you inflated? So we took a balloon extractor in order to try to see better the situation. And here
can you see now?
Endoscopically,
a fragmented stent coming out.
That we were able to treat this fragment not as a stent anymore, but as some stones. So by applying pressure either in the balloon or inside the pancreatic duct, we were able to do this because since the stent is not any more rigid, he will break every time we try to. There is still a piece over there that
Can you see? Yeah. Right of the vertebral spine.
Where the marker are. So I would say, let's do one last passage, and then we should go there again with the Dormia basket, because this is still the last one.
Professor, I think you can consider some pediatric forceps which are very flexible, and they can go and you can, it's worth an attempt. Because if you can grasp it, you'll be able to pull it with us.
Yeah.
We have a lot of those options here.
Yeah, that's a good idea.
See that? Now we have understood that this is the last pieces. This is a very good idea. The only problem that I have with the forceps is that since the stent is not rigid anymore, I'm afraid that it won't work because it breaks. So I would say, let's stay there like this with the guide wire. There are two pieces. One is just down here, and the other one is up there. Deflate. You see, there is one here nearby the balloon that I'm trying to see if I'm able to catch, inflate here. Fully inflated? Okay. Let's see.
Fragment.
The fragment is coming with the balloon. See that? And now it's close here to the papilla. So it's very important. See that? Close to the papilla. See if it's coming with me. Otherwise, we need. See endoscopically that is coming. A pieces.
Can you see this part of the stent coming? Yeah.
Screen, please. So it's still there. I've lost the wire. Yes, yes. Okay, deflate. So we need to take out this first. That is just down. Okay. So I think now we can change the balloon and can do with Dormia again. So we can put...
Dr. Andaloni will just go to Dr. Inouye and come back.
So this is the problem, that every time we catch, it breaks. So we need something like, I think, the Dormia in order to treat them like small stones. Okay.
Dr. Andaloni will just go to Dr. Inouye and come back. Thank you.
Thank you.
Swara.
A 42-year-old female, this patient has dysphagia and regurgitation for the last 1 year. Her Eckhart score is 7. An endoscopy that was done showed a dilated esophagus with the distal end showed narrowing. Her HRM was suggestive of type 2 achalasia cardia, where median IRP was 22 and pan insufficient pressurizations were seen in more than 20% of the swallows. She has been planned for POEM. Over to Professor Inouye.
Sir Haru, your line.
Aha, hello, hello. This is a case of a type 2 achalasia. So, okay, so coming back to the esophageal, okay. So, this is a case of a case presentation has been done. Okay, okay. So this is a type 2, and the junction is like this, very tight. The position of a esophagogastric junction is 37 centimeter. So we will place a short myotomy in this case, type 2 achalasia, not necessarily place a long myotomy. So now we are approaching the anterior wall, and then so place a mucosal incision, and then wait a moment, please. Injection, please. Okay. Through the knife, I'm injecting, and then we are trying to approach here. Okay, slowly, slowly. Yeah, yeah. We have to extend a little bit more, needle out. And then I want to place a lateral incision. Not this is a horizontal incision to make the passing the scope into the submucosal space much easier. Of course, injection please, once again. Yes, yes. Now I try to inject in a distal esophagus, and then hopefully we can get in a space. Not yet, but hopefully we can. Once we get in a space, the procedure is very simple. Anyway, so needle out. Okay, I will use a spray and coagulate the submucosal fibers a little bit in order to get some space in a submucosal layer. Okay, looks good. Hopefully we can get in. Yes, we are in the submucosal space. So injection, please. Always injection makes anatomy contrast in between muscle layer and the submucosa. Okay, needle out. So point is when we perform the POEM, we are approaching closely to the muscle, not the middle of the submucosa. We are approaching closely to the muscle layer. Okay, wait a moment, please. Okay. Okay, this is a submucosal space, and then keep going. Okay. Need out. Okay, thank you. So now the energy setting display coagulation 3.5, but please increase the 4.0. Okay, thank you, thank you. Now we are increasing the power to 4.0. So we decide everything based on an endoscopy image. Yes, so compared to the ESD, okay, we need some space. So some lateral dissection, okay. Now we are going straight toward the esophagus. So injection, please.
Professor, whenever we are using a sigmoid esophagus, what is the technique to go directly? Because many times we lose.
Yeah, it's a good question. It's a very good question. So point is we can see circular muscle fibers.
Yeah.
We will approach the tangential, okay, the lining of the circular muscle. And then here we can see a large vessel. So close, okay, then close it. No water. Okay, just spray. That's all. Okay, need out. Okay, like this. So using the TT knife with food is very effective to get the hemostasis. We just spray coagulation. That's all. Okay, go straight. Going straight. There are several fibers that need out. So we can split it out. Okay. Then go straight. So we are watching the lining of the circular muscle and then approach perpendicularly, tangentially. Okay, injection please. Okay, keep going. We are closely approaching to junction. Okay, needle out. So the best dissection plane is you can see some coagulation on the muscle layer. It's a very good sign. At the time of ESD, we keep some distance from the muscle layer, but at the time of form, so we cut the muscle layer later, then injection please. Okay, thank you. Needle out. Okay, thank you. Okay. Then go straight. We are approaching closely to junction. Okay, once again, the injection, please. Okay, thank you. Needle out. The point is that some coagulation current goes to the muscle side. Then we can confirm the lining of the muscle layer very well. Okay, go straight. Okay, injection, please. Okay, thank you. Needle out. Okay, thank you. Thank you, thank you. We are closely approaching to the junction, I hope. So lateral cut is very important. Okay, go straight. So back up a little bit. We can see this is the mucosa entrance. And then some mucosal tunnel has been created like this. Okay, some fibers attaching to the tip of the, okay, anyway. So we are approaching here. Injection, please. Okay, good. Needle out.
Professor Inouye, we'll
Yes.
just switch to the next OT and come back to you. Thank you.
Yeah. Welcome back.
And most importantly, we were able to bring back also the higher one. So let me tell you why I'm not using, the forceps. Because, to be honest, we have a difficult access to entering into the pancreatic duct, even with the guide wire. So we have the feeling that it's not so easy. At the moment, we were able to bring the fragments down, and so we want to try X-ray to fish them like this, changing always the axis of the dormia by moving the scope in this direction. See? and then trying to catch like this. So it's very important that you move either the dormia or the scope to change the angle and to try X-ray and to try. See? It's moving, but we are not getting. Okay, we need to try to be more, okay, X-ray. They are still there, we are not getting, but I have the feeling that we were able to move. See? Okay, so this is a good situation. When you do this, you can start closing slowly, and I will bring the catheter, and as you can see, the stent is moving. You don't have to close completely.
It's a very good maneuver. Everybody should appreciate
Let's
that.
say if we are able to
You push
see
the basket in the axis of
endoscopically,
the stent.
let's see if we are able to remove. See? See the other piece? Is over there. So two good pieces, close, close. So that was a good fishing day for us. Okay. Okay, stop with the machine. Actually, we had two pieces here. So maybe we were lucky. So open widely. Another technique is when you are opened, you can also flush with water in order to move. Stop, stop. So to move a lid, yes, 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 yeah, okay.
So we need to stop because the machine.
I know. We are going to do the last move. Okay, the water is very important. So we are going to stop. We are going to do the last few maneuver because we have a little problem with the X-ray. But look at this. I think we did a great fishing maneuver. And the last one will come either by dormia or by balloon later on. Okay, let me check here. This is not coming. X-ray. Okay, it's over there. It's over there. So I need to do this. Look at this movement. I go left with the instrument, and the axis will change. But now the X-ray machine is getting us. So I think that if we have this kind of problem, we can there leave a stent in because we have done the dilation. This is a chronic pancreatitis, and come back later on. It's very important to do this movement, not only to act on the catheter, but also on the scope. Screen, please. See? We are able to straight the pancreatic duct and hopefully to get something. So my friends here are very happy because they feel that something is inside, but we need to check and to keep the wire in. Wait.
Dr. Andoloni, wonderful
Yes.
demonstration. We'll just go to the next case. Thank you.
Okay, we have almost finished here.
Thank you. Dr. Inouye, you are live.
Yes. So now we are approaching close to junction. So when we approach close to junction, we keep some muscle layer, okay? Muscle layer surface, we follow. Then you can see, okay, this is the junction, okay, needle out, needle up, and then spray. Close to muscle layer.
Professor Inouye, what are the techniques to prevent mucosal injury at the G junction?
So at the level of a G junction, we have to repeat injection. And then when we create a submucosal tunnel, like this case, a little bit junction was tight. Then combine with the surface myotomy as well in order to keep space. Now we are getting a gastric side. Okay, so injection please. So once again, we can see a large vessel. This may be large vessel. We will coagulate close and just spray. No change of energy settings. Spray coagulation 40. And then so we can easily get the hemostasis. It's not necessary to use a coagula spa anymore. So that's all. So we are in the gastric side, several vessels, we can coagulate, just touch the surface and the splay, that's all. Okay, then we are in the gastric side, okay? Injection, please. Okay. Then so we can perform some myotomy. Back up a little bit. Okay, thank you. We are starting myotomy from here. Okay, need out. This is a myotomy, anterior myotomy. You can see a circular muscle bundle, so we can continue myotomy. Okay, now you can see outer longitudinal muscle layer. So we perform the inner circular myotomy. Like that. You can see this one is outer longitudinal muscle bundle. Okay. Okay, sorry. And then this one is a circular. Well, we just cut a circular muscle. Put the triangle plate on the longitudinal muscle bundle and then pull down the circular muscle and then cut. Energy setting is always a splay coagulation, that's all. Very simple. Okay, put a plate on the longitudinal muscle bundle and then down force.
Professor, what are the techniques if from the cut muscles if it starts bleeding?
Aha, so usually no
they retract.
bleeding. Yeah, usually no bleeding, but even when we encounter bleeding, we are using splay coagulation. Okay, anyway, so this part is our outer longitudinal muscle layer has also been dissected, but doesn't matter. So open and close, okay?
Professor
Okay,
Inouye, I think...
yes, thank you very much. Because of the char avoid. Okay.
It's interesting because most of us use
okay,
cutting
now
current
we are
for the
approaching
myotomy.
lower esophageal sphincter. Now I'm using the cutting current. Okay. This one is a longitudinal, so we will follow.
Professor, what is the reason for using the cutting current in that area?
Yeah. So any current we can accept, but in this case, less bleeding, so we can use a cutting current. Yes, like this. Okay, anyway, this one is a longitudinal muscle. Put a plate on the longitudinal muscle and then advance endoscope. Then we can catch the circular muscle and a little bit down force. Okay, we can cut the muscle like this way. Of course, we can do inside out as well. Esophageal side, we rarely encounter the mass bleeding, but gastric side, we have to be a little bit careful. Okay, but in this case, so this must be a lower esophageal sphincter. So step by step, careful watching. Okay, this is a lower esophageal sphincter. Okay. Okay, go ahead. Keep going. Most important is the anatomical recognition. This is a circular band. Okay, remaining the longitudinal muscle bundle. Okay, this one is a circular. Okay, so we are closely approaching to the junction. Okay, injection please. At the very end, so injection into submucosal layer make a contrast. So now we can recognize the anatomy much better. So I can say that the mediastinum is really open, and this one need out. This one is a longitudinal muscle bundle. This one. And then so we try to cut the behind the large vessel. It's not necessary to approach that one. Okay, abdomen is a soft and flat, no pneumoperitoneum, and then using a spray current.
Professor Inoi will just switch to Dr. Yamamoto and come back to you.
Yes,
Thank you. Dr. Yamamoto, you are live.
So a bit complicated resection because of the piecemeal multiple resection. So I have to design how to close the defect. Yeah. Sorry. Okay, close. Okay, fire. Okay, another clip. Yeah, and open. And close. Just a moment. It slipped. Open again. So I have to start. Close. Maybe how about the other side? Gripping the other side as well. Yeah, open again. Close. Looks good. Okay, fire. So what I want to tell you is you have to be careful not to resect the papilla pata, but accidentally I did. So stent is necessary. This was a papilla pata, so you have to be careful. I was not careful enough. Sorry about that. So that area was a bit distant from the main polyps, so I should notice that was the papilla pata. Okay, open. Close slowly. Oh, sorry. No, didn't work. Yeah, when you close the clip, I have to suck the gas, aspirate. Otherwise, close.
Dr. Yamamoto will just come back to you.
Yes.
Please continue. Thank
Okay.
you. Swara, next line.
It is a 51-year-old male. He's been having dyspepsia for the last 2 months. A sonography which was done which showed a dilated stomach with pyloric thickening. A CT showed the presence of a 2.5 centimeters gastric GIST. An EUS confirmed the same. An FNB was taken which showed a low risk GIST. These are the endoscopic and EUS images. Over to Dr. Zahir Nabi for EFTR.
Dr. Zahir, you are live.
Hi, good morning. So, do we have the endoscopic view? So, this is a very small diminutive gist that we have here in the antrum. And to just briefly give you the background, this patient received imatinib, and I assume that patient was not willing for surgery, and but got convinced for endoscopic resection. This is not growing very deep extraluminally. This is mainly intraluminal. So that's one positive thing for us, that this can be attempted endoscopically. It's large. It's more than 3.5 centimeter, which is usually the upper limit that we decide to resect. But then, having said that, it's not a rule that you have to resect only till 3.5 centimeter.
But Zahir, if the lesion is more than 4, there are more chances of malignant. Of course, all GIST have malignant potential, but more than 4, I think, should not be done with endoscopy.
Yes, sir.
You
So
can do
it, but you should not do it.
Yes, there's a difference between can do it and should not do it. And I think that the volume that is visible now endoscopically, a large portion of it is necrotic now. If we did a repeat CT, I guess, and the repeat CT shows that post imatinib, a large part of it is necrotic and is not active, I believe. So that is another reason that even despite of being large, the decision was taken for endoscopic resection. If you see that the hardness of the lesion has come down, it's more soft now, and the reason being that imatinib was provided for quite some time.
Gaurav, how many months imatinib was
So
given?
we diagnosed this in Jan, given 2 months of imatinib, 400 mg, and we've stopped it for the last 1 week. The reason for
And why
that
did you
is-
stop? Yeah.
So before resection, there are two important things. Is one is bleeding because of this VEGF activity, and second is post-operative. There is the imatinib acts on your interstitial the cells, so the cell membrane. So which is why
Healing would be a problem.
Yes, healing is a problem post-imatinib. So either surgical or endoscopic resection. And one of the reason why this patient was chosen is the surgeon said this will be a very radical gastrectomy, gastroenterectomy, and probably he'll have to do a GJ. So we kept that on standby and offered the patient if we can salvage a
Yeah,
major
definitely
resection.
this patient would need GJ because you
Yes.
do partial gastrectomy and gastrojejunostomy. Yeah.
And the
Roux
third
and
thing
Baird,
is
yeah.
we got a tissue pre-hand. This is a low-grade GIST. It's G1. It's a low mitotic activity. So we're quite comfortable in that way that maybe we can get a a good resection in this case.
Close.
So what's the plan, Zahir?
So let me mark this lesion first, because the moment that we inject, I'm going to lose the vision, because you can see that not very well defined margins on this side. So by palpating, I'll put some marks here. My plan is to make a incision, make a deep incision along this side first, along the duodenal side first. This is not tumor, this is a thickened fold. So I believe that if incision can be safely carried out along this side.
Is it thickened fold, or because of the weight of the lesion, there is fold formation?
I think some inflammatory reaction is there, because it doesn't look that there is something
that
beneath
the
it.
weight of the lesion has caused
Weight of
this.
the lesion
Yeah.
probably. So incision along this side, because this will be the rate limiting thing. Once we dissect, this will be the difficult part. Gaurav also believes the same.
So yeah, so the difficult part of the resection would be towards the pylorus, and we want to get the difficult part for at least get some proposal, margin on antral side. Yeah.
So for marking, Zahir, what are the current you are using? Forced coagulation?
Yes. I'm using forced coag, setting of 4. The setting is less, maybe around 2 if I'm marking it at some other place.
Stomach is fine.
Stomach, it's fine, because wall is pretty thick, and if the settings are low, then the marking is not very effective.
Yeah.
The main other challenge will be to close the defect. So
Are you going to use suture, or are you going to use clip in line? So
let's see the shape and
how it
size of the
goes, yeah.
defect,
Yeah.
and will be flexible.
So, Zahid, the most important thing to do all this procedure is you have to be confident about your closure, right?
Yes,
Closure
yes.
is the rate limiting factor.
Closure is the rate limiting factor. I think a large loop and clip can do the job. In my practice, I'll keep that this patient nil per oral for at least 48 to 72 hours with a Riles tube aspiration going on for 3 days. Subsequently, I'll do an oral contrast study just to make sure that there is no leak, and before starting any oral light. So this is important, no doubt about it. And truly speaking, all these cases, there are borderline cases where the judgment to remove them endoscopically, they are not straightforward. And at some point of time, you might have to take a call that whether you should really go ahead or take a call on laparoscopic. But having said that, as Gaurav told, that this is the surgery is going to be not straightforward. It's going to be a gastrojejunostomy. So that is another point.
Yeah,
that,
this is very important. Local resection in this area is not good enough, because you will have stricture, you will have change of axis, and patient will have starting symptoms of
Absolutely.
gastric outlet
Yes.
obstruction, even though the pylori is open.
So
Now,
I
what's
think
the
that's where,
depth of invasion on
combined
the EUS?
resection, if you can
Yeah.
reduce the size of the defect and probably close it, that's where.
Yes.
Zahir, on EUS, what was the finding? Was it involving the muscle layer or not?
Yes. Definitely, it's a large gist, so it's expected that it's involving. But what's more important for me, not the involvement of muscle layer, because it's a gist, and as a rule, it should involve the muscle layer. The most important thing is what is the exophytic component. So I
what if
have
there is
a
significant
cystic
exophytic?
patient. So if the lesion is exophytic, when you resect, the full thickness defect that you create is going to be early in
Much
your
bigger.
course of resection.
Yeah.
And so you need to be ready with your needle drainage and everything, so that you can drain that capnoperitoneum. So now you see, as I said, that once we inject, the site of the lesion is blurred. So what I'm going to do is I'm going to incise this portion first and then we'll inject again. So I'll preserve the sites first and see that if I can go above the lesion and below the lesion well or not. Stir is
can you
not
just
very effective.
can you just enucleate these lesions? I'm just asking, rather than going circumferential, just make an incision over the lesion and then go by the side.
In my experience, very difficult to just enucleate these lesions because of their attachments. That's a good idea, but when you try to enucleate them, it's very difficult, especially to enucleate them along the mucosal surface. So this is the first part. I want to make sure that my distal end is well incised so that the later part of, so this is not for the present part, the later part of the procedure will be a little more
So what
controlled.
current you are using? Are you
So I'm
using
using
endocut
force
or dry
coag,
cut?
force coag and endocut.
So for incision endocut and then for dissection force coag.
Force. So to make a quick incision, I used setting of effect, duration, interval, all two. I can increase the effect to 3 or 4 if I find that it's more. But since I am doing a tap, 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 doesn't matter much.
Dr. Zahir will just switch to Dr. Inouye and come back to
Yes,
you.
yes, yes.
Thank
Sure.
you. Professor Inouye, you are live.
Yeah. Okay. Now we have completed the myotomy. The myotomy was completed at the level. Now we have advanced endoscope. And then, so here you can see a large vessel. This one, a large vessel. It's not necessary to cut this. Muscle layer has already been dissected here. Okay, wait a moment, here. So esophagogastric junction is a 39. So now the position is a 40. So I think this is a gastric side. Okay, there are lesser omentum. Okay, need out. Okay. The gastric wall getting thinner, so I think it's okay. And these are the submucosal tissues. So in this case, actually there are lots of vessels. It's not necessary to cut this. Both sides, muscle layer has well dissected.
Professor, won't they bleed?
Yeah. At this moment, so no bleeding, so I think it's okay. So the middle part of the esophagus, you can see that this mediastinum is open. The both sides, there are cut end of the muscle. Okay. Then we may confirm. We can confirm it using a double scope. Someone please insert a double scope through the mouth. Yeah, whatever you want. So you can go through the nose or mouth. I can take it out. So we would like to confirm the myotomy position using the double scope. Yes. So once we take some other scope out, and then so assistant, so doctor, yeah, so he will insert the baby's. Yes, yeah, whatever you want. Okay. Lubricant, okay.
When they are inserting the scope, can we go to the Zahir's room?
Yeah. So
Zahir, you are back.
Yes.
You were saying tap, tap, tap. When you do tap, 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 it is more cut
It's more,
rather than the coagulation.
Yeah. It's like then I can immediately revert back. It's relatively more controlled. Although it's said that the best way to use endocut and full benefits of endocut is that you continuously press the paddle. But I believe when you are making a mucosal incision, the best way is to gradually do a tap. For example, I'll just show you here. Single cut, 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 cut. So I believe that's more controlled and I believe safer way of doing it.
And Zahir, you're using a TT knife, right?
I'm
Looks
using
like.
yes. I believe that the large part of dissection can be carried out using spray coag, and this is only for stomach and not for other parts of the GI tract because the wall is quite thick. And anyhow, we are going to do an intentional perforation in this case, which is important, and which means that we are not basically looking at perforation as a complication, right? So that's the reason, the main reason not to use this knife for ESDs, inject please. Not to use this knife for ESDs is that it is very large and the chances of perforation with this large shaft are high. But in cases like in this one where where the wall is quite thick, you need a bigger knife, I believe. Dual J, even the 2 mm one is sometimes falls short. For mucosal lesions, I believe dual J knife is very good. But for large submucosal lesions where you have to do a lot of dissection, the current settings, the type, for example, I'm using spray coag right now. I changed force coag to spray coag because the dissection is going to be a tedious process in this case. At some point, we are going to take a call regarding full thickness resection. I'm just trying to first see that what is the time point when we really reach the lesion. If I'm able to preserve the mucosa, why not? I'll be happy to do that. But this is more often not the case in cases with GISTs, and it's very difficult. And stir is like, in my experience, is practically not possible for majority of the large submucosal lesions in stomach. For some cases, especially those close to gastroesophageal junction, I think stir is a better option. But for cases where the lesion is far off and you don't have a direct tunnel, and such a large lesion is very difficult to remove from the tunnel.
So Zahir, at what point you will want to when the mucosa?
Yeah. So very, very relevant question. Sometimes it's difficult to differentiate when the muscle is bulging. So now you can see the bulge of the muscle. Will keep on palpating the tumor. See how soft this is now. Post-imatinib. I think it's a imatinib effect. There are two important things that I remember, that I don't hit the lesion because that will compromise the margin. And second is I palpate. For example, here I see a upward reflection, which means that somewhere here the tumor is arising from the muscle. Can you see this transition point here?
Nicely shown.
So this transition point probably is the point where I'll inject, I'll clear. The reason of having adequate planes here is that this is the point where it's closely attached to the muscle.
Zahir, we'll just come back to you. We'll go to Inoi's room.
Sure.
Dr. Inoi, you are on.
Yes, thank you very much. So this is 30 seconds. So now the baby scope is in a submucosal space, the end of the submucosal tunnel. And then mother scope, we can identify the light. Please move the scope.
We don't see any PIP, so we, no, it's still IITV. We need to see the PIP.
Some confusion.
No, we don't see
so
your
this
light.
Is the baby scope image.
Yeah. So now we are seeing. Now it's okay, yeah.
Now you can see open hiators, and the light is coming to our the gastric side, 1 centimeter distal from esophagogastric junction.
I think both the pediatric scope and adult scope is there. The pediatric scope is in the cavity, in the tunnel,
Stomach.
and Professor Inoi's scope is in the stomach, and we are seeing the light there.
Yeah, so definitely we
remove this?
please remove this. Okay, thank you very much. After this, so we close the mucosal entry using prefix.
Can I remove?
Okay.
So, Professor, are you going to do poem F or just this plain poem?
No, this case, poem is okay. We don't perform the poem F prophylactically. So,
Okay. So, when would you do poem F?
if the patient becomes a severe reflux, but so we don't have, we control the myopathy range using this double scope technique. So we don't have no severe GERD patient after poem. So because, we have our RCT data, and if we place a more than 3 centimeter gastric myotomy, patient becomes a severe reflux. But, so like today's case, 1 centimeter or 2 centimeter from the junction is a less risk of a perforation,
reflux.
severe GERD. So
Thank you.
I request you the clean lens, please. After this, we will close the mucosal entry using clips.
Okay, can we go back to Zahir, please?
Yeah, thank you so much.
Thank you, sir.
Dr. Zahir, you are live.
Yes. So we are getting a glimpse of the lesion
the tumor,
itself.
yeah.
So this is all the job that we have done. We have the vision of that transition point, which is somewhere here. And you see the behavior of the lesion right now is not exactly like a GIST, more of towards lipoma side. The reason being that it has been
I think stomach,
softened.
so muscle attachment is still far away. Do you think it is?
Yeah, I think
it is
we'll be gradually reaching towards the insertion point. But somewhere
what you were
it's
showing was not the insertion point. And of course, you need to dissect and then only you will come to know.
Yeah, completely agree with you. So, lot of
You are still using spray? You are still
I'm
using
still
spray?
using spray. The moment we reach close, we'll take a decision whether
Yeah, you
we should.
let us know when you are switching the current so that we know.
Sure. So the idea is like to dissect fully till the point here somewhere. I do believe that we have some insertion point, but it's like unless we reach the point, we don't really know.
Many a times you see these muscles are actually, splayed and they are arising, having a broad
Yes.
attachment.
Yes.
So one particular point is not always.
Yes.
So it's.
But Gaurav, otherwise also when you do ESD, gastric muscles splay and they get separated many times that it's perforation. It's not perforation. They just separate out.
Correct.
So far, I believe that we are below the lesion. What do you think, Dr.
I think you are still below the lesion, yeah.
Yes. So as
Now
long
you
as
see
I'm below
at
the
6
lesion and I'm
yeah.
able to dissect it, I'm happy. The idea is to delay the intentional full thickness defect for as long as possible. I know at some point, because that also delays our other parts of the procedure like needle drainage and all.
Can you put some injection over here?
Needle out. So still we are preserving this part of the mucosal flap just to see how it goes. And because clearance of sites won't be a big issue.
Yeah.
You just have to cut the flaps, the side curtains. But this
so in
is...
stomach, does the gravity help or it doesn't help in stomach?
It does help. It does help. I think at some point of time we may...
So when you are cutting the side, you will first cut the gravity side or
yes,
the anti-gravity?
I'll first cut the gravity side because that will be the more difficult one to...
Yeah, once you start cutting anti-gravity, the lesion falls and then it becomes very difficult to cut the gravity side, yeah.
Suction. That's another advantage of spray coag.
Yeah, that's what I was going to say.
Inject, please. Because now we are encountering bigger blood vessels. So let's see.
Probably you are not now going near the tumor. That's why, yeah.
Yes, yes, yes. And in fact, this is one of the signs that you are close to the lesion.
But you are smartly avoiding big vessels, huh, Zahir, I must tell you.
Yeah, yeah. Once we go off live, and then I'll be doing all that mess. Right. Inject, please. Inject. Needle nikal kar. So if it gets blocked, then you can always take it out. One problem is with spray coag that the tissue sticks a lot.
Carbonization and charring.
Now you see, once we were just close to the marks when we made an incision, but still the tumor is far off. So which denotes that the lesion is quite deep, and what we could see was just an impression and guess that we should start here. But the actual lesion is quite far off. See the amount of dissection that we have already done is, so this is the entire dissection that we have already done. We have a mucosal incision intact along this part. So which means that once we have done with the attachments, knife out.
So there are two things. I think they changed to. Yeah, you come back. So two things, Zahir. What are you injecting?
Sure. So methylene blue. This is methylene blue. Methylene blue.
With what?
With saline. Saline.
Not the lipos, not the lipofuscin, not.
No, nothing.
No,
Nothing.
normal.
Normal saline, because inject please. Because I feel these submucosal lesions you need to inject again and again to get a feel also.
And then that lot of bubble with gelofuscin. What do you say?
Yeah. And somehow I don't like the feel of dissection when I'm using gelofuscin. Probably because I'm not very much used to gelofuscin.
But you are from AIG. You must be having access to all these fancy.
Yeah. But somehow getting used to normal saline, you lose the interest in normal saline. So I think so far so good, because I believe the major part of the lesion is probably submucosal, and that makes our job so far a bit convenient.
Can you tell us something about the distal margin? What should be the depth of the distal incision?
So the distal incision should be quite deep. I supplemented the initial incision with another set of coag current, so that it is at least crossing 1/3 of submucosa, because we may overshoot otherwise if the please. If we are not very deep, then we may overshoot. Then overshooting problem is that side is duodenum. I don't want to overshoot towards the side of the duodenum.
Zahir, what's your thought on using an IT knife in sort of dissections through this area?
Shoot. In this case, like Zahir said, you don't want to go.
Yeah, Gaurav, again, keep your mic.
Error is very.
Yeah. So I think you were saying that Zahir doesn't want to do a blind dissection with IT knife because he doesn't want to touch the tumor. That's what you were saying, right? Because your mic moved and
yes.
Dr. Zahir will just switch to Dr. Inouye and come back to you.
Sure.
Professor Inouye, you are live.
Fire. Okay.
Professor Inouye.
Yeah. So we have already closed mucosal defect like this. So totally completed both sides. We have already checked. Okay, like that. Mucosal entry has been already closed. And then, so junction. Junction is open like this.
No resistance.
No resistance at all. Okay, thank you very much for your attention.
Thank you, Professor Inouye and Dr. Ravindra.
Okay.
We'll switch to Dr. Zahir.
Thank you.
Dr. Zahir, you are live.
Yeah, so we were just discussing about different currents, like why spray and why not forced. And so I think for bigger lesions where there is a lot of submucosal dissection to do, spray can be handy.
Yeah, at least in the stomach, I think it makes a good sense. Maybe in the rectum also. But this is the first time I'm seeing spray being used in submucosal dissection. But it's going on well so far.
Yeah. So Zahir made it clear only for stomach and only for stomach, right?
Yes,
Zahir?
yes. It's very important because this is the highest voltage current that's in that case. That's
And also TTJ, do you do ESD with
No,
TTJ?
never.
No.
So it's like tunneling procedures which involve a lot of submucosal dissection. TTJ knife is really good. The main reason being it's a long knife, and spray is meant for TTJ knife. Like TTJ knife was, I feel, no other knife works better than TTJ knife if you are using spray coag.
But Zahir, in this case, so far we're not seeing deep muscle invasion. So I think it's almost like an ESD right now.
So
with,
yes,
TTJ knife. So
yes. So far there is no deep deep muscular invasion we have seen. There may be some muscle fibers that we have cut, but they were superficial muscle fibers, so we are not bothered. So we have to always be flexible in our plan. Otherwise, we'll go ahead with full thickness resection right in the beginning. Then it will be a tough call for the anesthetist also. Because capnoperitoneum, if you make a big hole here, is going to appear very quickly. And although it can be taken care of, but if you can avoid it or delay it, I think that's a reasonable strategy.
Zahid, if you are on a dual knife, we have on a dual knife, would you still go ahead and do the procedure? Dual knife.
Dual knife?
Yeah.
So dual knife is a very good knife. There's no doubt about it. And I use it along places where in smaller ESDs, yes. Gastric ESDs, 2 millimeter dual knife is good. And here I believe that...
Yeah, I think we've reached a point where you can see the tumor arising.
Yes, from the muscle,
Yes,
there is
especially at the lower end.
So right now we are seeing at 6 o'clock the tumor, 12 o'clock is the mucosa and submucosa. 9 o'clock, maybe not 9, 7 o'clock, there is a tumor attachment,
Correct, yeah. So this is the point where you have to, strategize properly. Do you want to go in and
I think now is the time for IT knife.
Or Zahir, would you want to open the...
So that opening part I'm going to do still bit late. I'm going to, because see, if I open it and I keep on clearing these fibers which don't require any muscle opening, then it's a futile effort, right?
Correct.
So I should be sure that I have cleared all the attachments, and now is the time that I have to open the muscle. Because after opening that, I have to be quick enough, even though we can always manage capnoperitoneum, but I want to delay the appearance of capnoperitoneum as much as possible. I can also see that I can go above the lesion, and I'm going to have a...
So that is what I was asking. Are you going to detach it from the mucosa?
I will try. Definitely I will try. And then it may, if I'm able to detach it, some may question that why did we make a distal mucosal incision? I think the reason is at the end of the procedure, it's very difficult to make that mucosal incision. So that's the reason that that distal mucosal incision is not full thickness. So I'm not very much worried that that mucosal incision is going to produce any trouble. So now I can see a bit of tumor. I can see a bit of attachments above, and I'll try if this can be. So no hurry to make that full thickness call. I think we will have to go inside after a while. But before that, make sure that Rest all the attachments have been cleared, because the less time you spend after opening the muscle layer, the better it is. This is what I believe.
So it's not just CO2, it's fluid, it's blood, it's a lot
Yeah,
of
it's everything.
tissue which is going into the peritoneum. And by principle, you want to avoid such contamination.
Contamination, yes, exactly.
So post-operative
Moreover, the
recovery is,
peritoneum is also less exposed
Yes.
to the gist, because this is one argument that's always given by surgeon, that you contaminate the peritoneum, and there may be some peritoneal seeding that may happen. So this is another argument that goes in favor of delaying the mucosal defect, the muscular defect.
I would like to interrupt the session because we have the time for endoscopy update. We are already delayed for that. And we can come back to the surgical thing after we've finished with this, if there is something which is left to be shown.
Yeah.
So I thank the moderators for moderating this live session. And as chairpersons for the endoscopy update, I would like to call upon Dr. Akash Shukla, Dr. Shrikant Mukhewar, Dr. Somil Vyas, Dr. Pramod Shinde, Dr. Amay Sonavane, and Dr. Ajit Tharakkan to please come up on stage. We have 3 lectures here, and the first lecture is of 30 minutes, and the rest 2 are 15 minutes each. The 30-minute lecture includes 20 minutes of lecture and 10 minutes of discussion, while the 15 minutes include 12 minutes of lecture and 3 minutes of discussion. So I hand over the session to the chairpersons to invite and introduce our first speaker. So the introduction slide is right before you, so you can invite and introduce him. Also like to make an announcement while the chairpersons are getting ready that the cyanoacrylate glue, the Endocryl, is made available at Endotech counter. So those who are interested can buy it off the counter. Thank you.
So for this next session, we would like to invite the first speaker. This is Professor G.V. Rao, who is going to speak on endoscopy surgery interface. So over to you, Professor Rao.
Thank you. Thank you, Akash. Thank you, Amit, for the honor of this podium. Beautiful dissection that's been going on live. Sorry to interrupt Zahir for that, actually. If you look at surgery, people, all the endoscopists have been talking about the morbidity and mortality of surgery, basically because of the bleeding issues, the leaks, the blood loss, and the extensive resection that are done surgically. Minimally invasive surgical techniques have endoscopy, laparoscopy, and robotics have shown to decrease the morbidity of many of the surgical procedures, basically because of the flexibility of some of these minimally invasive techniques, the maneuverability, the orientation, the instrumentation, the energy sources, suturing devices, and the staplers available. Each of these minimally invasive techniques have their own pros and cons, and we have to take advantage of the pros and cons of each of these techniques to make sure that some of these procedures can be done safely. Endoscopy in GI surgery, basically it's intraoperative endoscopy, or laparoscopy endoscopy cooperative surgery, or robotic endoscopic cooperative surgery. I'll give you an endoscopy which can be used to elevate lesions, intraoperative colonoscopy to check for bleeds post-anterior resection to make sure that you secure hemostasis, intraoperative enteroscopy to combine endoscopy, laparoscopy procedures for pan-enteroscopy, intraoperative ERCP wherein we inject indocyanine green into the bile duct to identify bile ducts, intraoperative cholangioscopy can be done, and intraoperative pancreaticoscopy. So intraoperative endoscopy is making roads into each and every specialty that we have in clinical practice. This basically decreases the morbidity that we have in the post-operative time. For all these things to have, we need to have an hybrid theater which takes up both the functions of the endoscopy and laparoscopy together. So we have 2 towers, an endoscopy tower and a laparoscopy tower. We have the subepithelial tumors which you have seen just now, which are being increasingly detected. We have better knowledge of their biological behavior. And we also know that segmental and minimally invasive resections are adequate for this. based on sound oncological principles, and we have good functional outcomes if you do conservative resections in this. So conventionally, as you're seeing, actually, whenever we have these tumors like this, like the previous case, which was going live, they said it could have been a distal gastrectomy for that patient. That's the reason why the patient opted for an endoscopy procedure. Very right, actually, when we started this, we used to do laparoscopic distal gastrectomy, maybe proximal gastrectomy, and even total gastrectomy in some of these patients with subepithelial tumors. But umpteen number of these combined endoscopy, laparoscopy procedures have evolved depending on the amount of endoscopic involvement and the amount of laparoscopic involvement to make sure that you get a complete removal of the tumor based on the oncological principles. Each and every name here is based on the amount of endoscopic or the laparoscopic involvement in these procedures. Predominantly, if you see, the type of procedure that has practice depends on whether the lesion is predominantly endophytic or the lesion is predominantly exophytic. For predominantly exophytic lesions, a laparoscopic procedure is ideal. For predominantly endophytic lesions, actually endoscopy is best. And we have a gray zone where you can choose between endoscopy and laparoscopy. And that is where the laparoscopy endoscopy cooperative surgery comes in between. A lesion like this, a huge exophytic lesion like this, simple sleeve resection would be enough. Why are we using intraoperative endoscopy in this? Basically to make sure there is no compromise of the lumen. And postoperatively, we check the staple line for any bleed, staple line for any leaks, so that we don't have any morbidity in the postoperative period. So as this stapler is being fired, the stomach distends. You can see that you can transeliminate the stomach, distend the stomach, and you can see the suture line being fired here. End of the procedure, we can check the integrity of the suture line or the staple line, and if there is any bleed, we can always control endoscopically. But the biggest problem of this is we are getting a bigger margin on one side and a smaller margin on the other side. This is the limitation of this. So for this, various other modalities have evolved. Now, this is another case, actually, a large lesion at the GE junction. Maybe a decade back, all these patients used to go for a total gastrectomy when imatinib was not available. So this was one of those things, laparoscopic resection was done. But at the end of the procedure, there was a bleed at the suture line. So we, instead of opening up the suture line again, used endoscopy to clip this bleeder. Again, use of intraoperative endoscopy to make sure that the morbidity is less in this patient. Now, see this lesion. This is a predominantly, we have learned a lot of lessons from the endoscopists now. Here we are injecting submucosal methylene blue here. Endoscopy, and you can see the bluish tinge on the serosal side. I inject this lesion all around the lesion here. Like what Zahir has done just now, I'm injecting the same thing endoscopically, but I'm doing it surgically right now. So what I'm going to do right now is, because this lesion is predominantly exophytic, now this we are going to start doing a seromuscular incision here. Like you've done a mucosal incision on the other side, now we start doing the seromuscular incision on this side. The biggest advantage of having an endoscope inside is we keep inflating and deflating the stomach, and this inflation acts as a retractor. It displays the two seromuscular edges. So whenever we want to coagulate anything of that sort, you can deflate the stomach. Whenever you want any retraction, you can insufflate the stomach so that the margins, the seromuscular edges get apart. So you can see this, you're continuously inflating and deflating the thing. And like what has been done on the endoscopic side, we're doing the same thing from the seromuscular side. So all around it is done. We can use either monopolar current or use harmonic scalpel. The advantage is that we have better energy sources on the laparoscopic side compared to what is available on the endoscopy side. So the dissections could be slightly faster. And you can see this, like what you have done on the endoscopy side, I know where the tumor is starting here, and we have a large mucosal tube which acts as a buffer for us. And once this is done, and once we know that the entire lesion is, then we apply the stapler. The stapler is applied to the mucosal tube, and then do a complete resection. And after that, this can be put on the endo bag here, There is no breach of the mucosa here. And then we do a seromuscular closure here. And at the end of the procedure, we check endoscopically to make sure there is no bleed inside or there is no leaks inside. So for predominantly exophytic lesions, a combined endoscopy laparoscopy procedure can be done like this. Again, this is a lesion actually close to the G junction here, I mean on the lesser curve here, not palpable laparoscopically. Then we dissected the lesser curve here. Now, the transillumination helps to identify the lesion here. Then you do a full thickness resection like what has been done on endoscopy side. And then you do a full thickness resection from the laparoscopic side. Basically, we have better energy sources. The procedures can be done safely. The biggest advantage of using this endoscope during this procedure is we have to get the endoscopist also trained to how to move in the peritoneal cavity. Putting this lesion into the bag is very easy laparoscopically, but for an endoscopist to pick it up and put it in the bag is a humongous exercise. So when you're practicing these procedures, we have to allow the endoscopist also to do some of these maneuvers in the peritoneal cavity so that as and when arises, both the endoscopist and laparoscopic surgeons can work together. When it is done, then you suture the thing and then get away from the thing. Again, a lesion like this, actually what was initially said, actually this lesion would have, suppose if I put a sleeve, this would have compromised the lumen of the stomach, and I would have required a distal gastrectomy very rightly. So here what we're doing is a combined endoscopy laparoscopy procedure. I tried to put a stapler here, and then I knew that it was compromising with the lumen. So what we did was a combined endoscopy laparoscopy procedure to avoid a distal gastrectomy in this. Injected submucosal methylene blue again here. We're doing the seromuscular incision. The mucosa is completely pushed away by the buffer of the submucosal methylene blue. I'll show you that. See, that is the submucosal methylene blue here. And you can see that we can push the mucosa away as you're doing the procedure. Use monopolar or a harmonic scalpel to do this dissection at a faster pace. And once it is done, you can see that that is the mucosal tube, that is a stapler that is being used to staple the mucosal tube. And you can see the stomach is adequately inflated. There is no compromise in the lumen there. And then once you've stapled it, so you can see the stomach is inflated. There is no compromise on the lumen here. And then you can see that is the mucosa on the other side, well vascularized. And we just have to do a seromuscular closure in this. Likewise, for early gastric cancers, actually, these things can be done through ESD procedures. Again, to prevent any spillage of these cells into the peritoneal cavity, you inject submucosal methylene blue here, lift the entire lesion off, and then again do the same thing from the serosal side. This is basically to avoid any spillage of these cells into the peritoneal cavity. And then you do a complete seromuscular incision. Then you close the seromuscular incision, inverting the lesion onto the luminal side. So you're inverting the entire lesion onto the luminal side. And as you're doing this procedure, this lesion can be made more prominent on the luminal side by putting in some tissue material like Surgicel here. You put a material like this lesion will become more prominent on the luminal side. So once you've done the luminal closure, it becomes very easy for the endoscopist to do an ESD procedure on this patient. So you're just helping so that you don't oncologically be a good, no spillage of cells into the peritoneal cavity. There are a lot of lessons that we learned from third space actually. Here now instead of injecting from the mucosal side, we started injecting from the serosal side. Now these are the lessons we learned from the third space endoscopists. So you can see this, we injected subserosally and using the monopolar hook to do this dissection. This is a basic principle that we learned from the third space endoscopy. So as you're doing the procedure, keep injecting and keep cutting all around the thing instead of going again onto the luminal side. I'll give you an example. Actually, I borrowed this speedboat from Zahir here. So we are doing the same procedure using a speedboat now. Any of these energy sources can be used, actually monopolar hook. I just wanted to see if the speedboat helps here, but this is very difficult for a speedboat on the serosal side because the seromuscular incision is seromuscular layer is more thicker than the mucosal layer. But you can see this, we can do the same dissection all around the thing. Want of time, I'm just running it through actually. So that's the entire lesion. Actually, you can see that the submucosal methylene blue completely lifting off the mucosa onto the other side. That is the mucosal tube. See, that's the mucosal tube, very well vascular. We've got complete resection, and you can use a stapler to staple this. And at the same time, you can see that the lumen, gastric lumen is not compromised. So you're avoiding a major gastrectomy in these patients whenever we are doing these procedures like this. So now we just can see that the laparoscopic light is off, trans-elimination showing a beautiful mucosal tube on all around, and we can staple this. Likewise, whenever we're doing this divertically, it's mandatory that actually we have an intraoperative endoscopy to make sure that you're not compromising on the lumen, and they can staple the thing, again check for the staple line integrity and also for luminal compromise when you are doing this procedure. This is a thoracoscopic procedure. Likewise, large leiomyomas like this can be very effectively enucleated. Again, endoscopically, we injected submucosal methylene blue here to make sure that the mucosa is completely lifted off and the lesion becomes very prominent onto the thoracoscopic side. We just have to split the longitudinal and the circular muscle fibers here, and the entire long, big tumor can be easily enucleated without disrupting the mucosa on the other side. Once the whole thing is enucleated using these energy sources that we have, this seromuscular or the circular and the longitudinal muscle layers can be easily closed using the conventional thoracoscopic laparoscopic techniques. And again, here, this is another huge SCT which is being done endoscopically. Same time, we use thoracoscopy to make sure that we don't have any morbidity in this patient. We are able to progress to an extent, but beyond that, it was not possible, basically because it was compromising. Then we switched over to the thoracoscopy to make sure that the rest of the procedure is completed, and then decreasing the morbidity in this patient. We were all prepared for this. We did this in the hybrid theater to make sure that we don't have any morbidity in this patient. After we enucleated, we were able to close the esophageal lumen thoracoscopically. I mean, because this can be done rapidly as compared to what we have, compared to the endoscopic suturing devices that we have. Again, migrated stents like this, actually, sometimes it happens, actually, luminal stent that can migrate into the peritoneal cavity or ill-positioned, these can be removed. This is for an endoscopic gastrojejunostomy that was placed. So we had to mobilize this. So like somebody was saying, these patients were not willing for surgery. There are also patients who are not willing for endoscopy procedures, please. I think we have to be very clear in this, actually. Both the procedures right now are done under general anesthesia. We do either endoscopic procedure, major procedures like this, or laparoscopy, or are done under general anesthesia. So I think there is, it all depends on how much of counseling that we're doing this patient. So this actually, we removed this and then completed for a laparoscopic gastrojejunostomy. Likewise, on the colonic side, there are a lot of indications wherein we do this endoscopy, colonoscopy procedures together, especially for polyps, actually. Here, I'll just show you an example of how intraoperative colonoscopy helps. This is a mucocele of the appendix. So basically, we would have done an IC resection or a right hemicolectomy if we had not had this issue, actually, combined endoscopy, laparoscopy procedure. Now, here, by trans-eliminating, we know the base of the tumor here. So you can see that the base of the tumor is very clearly visible here. Once we switch off the laparoscopy light, the base is clearly visible and you're away from the ileocecal valve. So you can just sleeve the cecum here, getting a complete oncological resection of this tumor instead of resorting to an ileocecal resection. You can see this when you switch off the thing, actually, we can see the beautifully and you can do a sleeve resection of the cecum instead of doing an ileocecal resection or a right hemicolectomy in these patients. So major surgical resections are avoided if you can combine the use of endoscopy and laparoscopy. Again, I'll show you another example of a large lipoma at the ileocecal valve, which is intussuscepting into the ileum, causing recurrent subacute intestinal obstruction. This again would have required a limited ileocecal resection or a right hemicolectomy. Here we mobilize the right colon, the appendix here. Then we are not able to localize the lipoma here. So what we did was to mobilize the appendix, made an opening in the slit in the appendix, used as digital spy here to pass into the cecum, insufflate the cecum so that the cecum gets insufflated. Once it is insufflated, by sheer transelimination, we are able to localize the you can see that we are able to localize the lesion here. By sheer transelimination, you are able to localize the lipoma there. And then once we have assured that see that that's a transelimination of the digital spy, insufflating the cecum here, check the lesion here. Then we made a small colotomy along the tinea coli, and then enucleated this lipoma of the ileocecal junction. And once you have done this, again, the scope was still in the cecum. We closed this small colotomy here. And then at the end of the procedure, again, we use the same digital spy to insufflate the cecum, make sure that the suture line was secure, no bleeding inside. And after that, we completed this appendectomy using this catgut loop here. That's the appendix there. Actually, then we use this catgut loop to complete the appendectomy. So we're using all endoscopy, colonoscopy, ERCP scope, digital spy, whatever is available there for doing these combined endoscopy, laparoscopy procedures. Large data coming up from across the globe, including our data, to show this combined endoscopy, laparoscopy procedure very fruitful, lessens the time, decreases the morbidity that we have doing these procedures. There's pros and cons of these procedures, but both endoscopists and the laparoscopic surgeons should practice together. There are guidelines laid down to see how much of the work the endoscopist has to do and how much of the work the laparoscopic surgeon can do. But ultimately, we have to work in tandem to make sure that these procedures can be done very safely. The other thing that has come is actually with the recent advent of robotics, now the same endoscopy is being carried into the robotic theater right now. Here is the first example of two lesions that we did recently. One is a polypectomy that was done, turned out to be malignant polyps, so we could not localize the lesion on robotic surgery, so we had to use intraoperative colonoscopy to localize this site of polypectomy and complete the anterior resection in this patient. Similarly, again, another thing, actually, early lesion in the rectosigmoid junction. When we're doing the robotic anterior resection, we are not able to see, palpate the lesion. Again, we have to use the intraoperative colonoscopy here to localize the thing and mark out the lesion and complete the anterior resection procedure. So for the first ever time, we use this in robotic surgery. It's slightly more cumbersome when you're doing robotic surgery because the robo occupies a bigger space in the theater as compared to the laparoscopic place. Cytoscopy is another one way we use actually. It can be used to check actually here, stain it with lesions, and then we can make an intraoperative diagnosis of a benign versus malignant actually. And then we use the same thing here for endobrain on the laparoscopic side in a patient with unexplained ascites. I'm not saying that this is what has to be done, but just to show you that how the endoscopic technology can be used on the laparoscopic side. In the days to come, we'll have more and more of these interventions coming up, and I'm sure that will be solutions for this. So here we're just targeting the biopsies. I'm not saying it is avoiding a biopsy, but it helps in targeting the biopsies as in today. Again, the entire exercise is to show you that endoscopy can be used liberally on the surgical side to make sure a lot of procedures can be done relatively safely, maintaining the oncological principles and lessening the time and lessening the amount of bleed that we encounter in this. Robotic surgery, actually, most of the clinicians feel that the robo performs. Unfortunately, it does not. Actually, it's aiding the surgeon as in today. There are 4 different moves that we do whenever we're doing a robotic or an laparoscopic surgery. Somebody shows you the lesion, we recognize the lesion, and we decide what to do and then move the instrument. AI is coming into each and every of these phases of this laparoscopy and robotic surgery. At the end that it is able to see, it is able to decide, it is able to move, and maybe it will start performing surgeries also. And the precision with which it does is almost about 90% plus. So putting in all these things together, we have this single port robotic surgery now. Instead of putting multiple port, which we are worried about, we have this single port robotic, which is a robo which has come, which can be put through the umbilical port, and we have these multiple arms which can be passed. It is something similar to the endoscopy, which we had a flexible endoscopy some time back. It's a robotic thing that we have with 3 arms together, which can perform these procedures very safely. But when you're combining all these, as I was talking about, for the first ever time, what they have done is an experimental model to show that AI can get into surgery or maybe endoscopy. For the first ever time, a small bowel resection was done on a porcine model. It is entirely simulated on the system first, made sure that each and every step that was done was perfectly done. And once the surgeon was confirmed, he was happy that the procedure was safe, he let the system do the procedure. In the sense, you're doing the entire system on the computer first. Once you're satisfied, you let the system do the procedure. The biggest advantage is actually most of the bile duct injuries that happen, bile leaks that happen during laparoscopic cholecystectomy, it is likely that these can be simulated before, and you let the system do the procedure so that you don't have this complication. Very primitive, but the way in which it is advancing, I'm sure this thing will see the transition very soon into clinical practice. So combined endoscopy, laparoscopy procedures, integrated with robotics and artificial intelligence is going to be a big field, big specialty as in today of tomorrow. So intraoperative endoscopy, laparoscopy, robotic cooperative surgeries are emerging specialties, and all the surgeons sitting here should have some knowledge of these things so that they can do these procedures very effectively. It's aiding both laparoscopy and robotic procedures, improving the outcomes. There's an increasing role of indocyanine green, infrared laparoscopy, and artificial intelligence in surgical procedures, and it is aiding in function-preserving physiological resections as in today. Now, these procedures can be safely introduced in a facility-based manner, either by the surgeons or the endoscopists with advanced skill. And as more and more surgeons are being trained in endoscopy, the indications will surely expand. There are a lot of limitations of haptics in laparoscopy and also on robotics, leading to increasing indications of these endoscopy, laparoscopy procedures, but it requires a very close cooperation between the endoscopies. The egos have to be shut down before we take up these procedures, and both of them are equally involved in the procedures. For some, the endoscopists could play a major role. For some, the laparoscopic surgeons could be a major role. I always keep showing these videos over and over again. 2 decades back, we had individual heroes, and I mean, Iron Man, Captain America, Thor. Each and every person had their own signature techniques and technology, but they had their limitations of those techniques and technology. And I think these people have realized the limitations of this. We don't get any individual heroes now. It's always combined effort of all these people which is making these movies, and people are getting to accept this. So I think the similar thing happens on the surgical side. Both endoscopists and laparoscopic surgeons have to practice together to make sure that these procedures can be done safely. Again, to end this, we are able to do, we have a very strong endoscopy department. Actually, you have seen Zahir doing a very major resection here. So if we are doing these procedures simultaneously on the surgical side, it means there is some indication or a gray zone where we do this combined endoscopy, laparoscopic procedures to make sure that we have best outcomes in this patient. Thank you so much once again for the patient here.
A very excellent talk, Dr. G.V. Rao, as usual. And we were thrilled to see the combined videos of all the endoscopic and GI surgeons working together. I just wanted to say that in our training program, hardly our surgeons would have seen the advanced third space endoscopic procedures that are being performed at centers like this, like a duodenal NEAT, NET or SEL. And in the similar way, the advanced endotherapists have not really seen what the surgeons are doing robotically and laparoscopically. So do you think that our training curriculum should uh, include a rotation for the GI surgeons into an advanced endoscopic suite for at least a half a term? And similarly, and the endoscopic should have a rotation in the surgical OAs also.
Absolutely right. Actually, people keep asking me, how is that I'm still able to practice endoscopy in my current day clinical practice in spite of all these legal issues? To tell you very frankly, the amount of endoscopy work that I do within the theater, wherein I'm not competing with the endoscopists, is so much that I can sustain my life myself. So I don't have to go outside my OR to do this endoscopy practice. So I'm not competing with a gastroenterologist doing a routine endoscopy or a colonoscopy or an ERCP. These are the procedures that are done inside the OT, wherein we are not competing with any of this professionally. But at the same time, we are cooperating with these people, and we are taking the help of endoscopists as and when required. And we are constantly in touch with what is happening on the endoscopy side so that we can incorporate those technologies onto the laparoscopic side to make sure that the procedures can be done safely.
Any questions from the floor?
If there are no more
we can close
questions,
the
before we invite the next speaker, sir, they want to show something live from the OT in a minute. We are connecting. Can we connect it?
Thank you, Doctor.
Thank you very much, Dr. Rao. We are, yeah, you are on, sir. Please
This
go
is
ahead.
a very interesting case. Post cholecystectomy liver injury, and we are doing magnetic reconstruction of the bile duct injury. As we know that bile duct injury is still common, and this is a wire guided magnet which we have produced, and this volume, yeah. This is a wire guided magnet which is produced, and this patient has a difficult anatomy. So this one, another magnet is a side by side anastomosis magnet, which is another innovation by us, because this will not, this anatomy which you can see on the screen is very difficult. You can see the screen. It is going by the side by side. So we will push the wire guided magnet first inside the bile duct up to the stricture. Yeah, and now my assistant Dr. Milan and Mr. Ashish is assisting me, and he will pass the second magnet to the common hepatic duct. So, yeah. So now he is slowly, yeah.
You need to push the magnet till the end, or
Yeah.
where
Most
the
of time,
cystic duct stump is there.
Yes. And now he will push, and the pull back. And now you can see the magnet will come out, and they will attract each other. Yeah, push, pull. So this is special magnets. They have been made for this type of difficult anatomy. Yeah, bar. And they will attract each other. Pull back. Yeah, now you can see how easily it has attracted it.
Fantastic.
Can you see?
Yes.
So now this will have an anastomosis within a day or two, or most probably within 3 days. These two magnets will attract each other, and they will form a good anastomosis, and then we can pass a guide wire through this, and then they have a communication with each other.
How do you remove these magnets, Sanjay?
We have a special magnet removal tube which we have made. This is a special magnet removal which contains another magnet through the wire. So it will go inside, and the magnet which is side by side anastomosing, that we can pull out through the PTBD with a Fogarty balloon.
But in this case, I don't think both will come out, I think.
Yeah, maybe they can come out. You can see the right anterior view. They are almost anastomosing now only. Can you see this?
Yes.
In the anybody in the hall?
Yeah, we can see it actually.
Yeah, we can. Yeah, you can see the anastomosis happening in front of us. So this patient is suffering from last 8 months with PTBD. Yeah,
Thanks.
can you see the side to side anastomosis now?
Yeah, no, it's visible. Thank you. Yeah.
Thanks, Dr. Sanjay. That was
Yeah.
lovely. We'll switch to Zahir for just a little bit
Yeah.
to show his
Thank you
progress.
so much. Thank you, sir.
Yeah, Zahir, you are on. Zahir?
Hi. So,
Yeah.
Yes, sir.
just to show you that dissected it from the surroundings. So this is the lesion. I'm just sucking some fluid so that you can have a better view. So just to show you, so this is where we started, right? So this is all around the lesion that you can see. Quite a lot has been dissected, more to be resected, pretty large lesion. But still, you see, we have not dissected it from this portion where it's adherent to the muscle, right? But rest all, we have made sure that we have resected the maximum attachments, because once we make a hole, we are planning to finish the procedure quickly. So this is all what we have resected till now.
It's
So there
looking
was
wonderful.
a broad attachment, as you can see.
Yeah.
Zahir, any
Attachment seen on the right side. So Zahir has very expertly, identified these 2 or 3 attachments that this lesion has to the muscle and dissected it from the submucosal tissue which is lying on it.
So Zahir, you did a distal incision. So the reason to do that was to not overshoot. Was that sort of the consideration, or I'm not sure if it's serving
For the
purpose?
distal incision?
Yeah.
So the main reason was that once we are we have done a bit of procedure because of mucosal edema and all. Even the marks are not visible, and the distal end, because it's like overlapping with the duodenum. It's like just adjacent to the duodenum, so that it's very important that we don't overshoot towards the duodenum, because duodenum is like a complete different ball game, and muscle injury will be very easy. So that's the reason that we made sure that at least the distal end we will decide. We'll make an incision so that once we are done with it, once we have detached all the surroundings, we don't overshoot. It's a bit mobile now. Can you see that? It's
Yes,
like
yes.
it's not as fixed as it was. So I think time has come that we take that call. So far, we have been escaping that. Little more attachments that are along this side.
Yeah. So there are some minute muscle attachments which you can see this aspect or the inferior aspect of the lesion. And there is a broad attachment which extends from
Sure. So,
the inferior
Zahir, we'll just go back to the
towards the
lectures now.
incisura. I think this is quite a large attachment if you still have to create a defect. What do you think?
Yeah. Exactly.
Yeah, we'll get back.
Yes.
We'll let
Yeah, I think you
Zahir
should take care of
continue
that
this. We'll go back to the auditorium to continue the lectures. And we'll come back.
Yeah.
Would like to now call upon Dr. Rajesh Puri sir from Medanta to talk upon endohepatology. Will it have an increasing role in the future?
I think we can now start. Sir, you can invite our next speaker. So I think it's here. Your thing is here, sir.
Good afternoon, everyone. At the outset, would like to thank Dr. Amit and the entire team for an excellent conference. And next 15 minutes, I'm going to talk endohepatology. Will it have an increasing role in the future when the conventional methods are also equally good? So if you look at the progress of endohepatology, a decade before, endohepatology means screening and the treatment of esophageal varices, gastric varices, and the portal hypertensive gastropathy. But in the last 1 decade, with an advent of endoscopic ultrasound, you can not only look at the lumen, but you can look outside the lumen and you can palpate the liver. And you can do the parenchymal and the vascular intervention in the form of liver biopsy, portal pressure gradient measurement, coiling of the gastric varices, and portal vein sampling, gene therapy, US plastography. And the most important advantage is you can do the multiple procedure in the same session. And I'm going to talk EUS guided liver biopsy and portal pressure measurement. Let's discuss a case, a 64-year-old male with a history of obesity who is undergoing evaluation for the kidney transplant, and he has a long-standing elevated liver function test, and on CT scan there is a certain nodularity of the liver surface with a few collaterals at the splenic hilum. And the question is, how much liver disease this gentleman has? Should he alone go for a simple kidney transplant or a dual transplant, or what is the risk of decompensation? So whenever a patient who requires a liver biopsy because of the abnormal liver function test, the three routes are possible, that is percutaneous, IR-guided, and EUS-guided liver biopsy. The percutaneous is more widely available, standard of choice, done with the 16 and 18 gauge bore needle. The problem with this is the risk of bleeding, an anxious patient, and post-procedure pain. IR-guided is very good for patient who has ascites, patient who has a coagulopathy, or an anxious patient, but again a problem of bleeding, hematoma, risk of puncture of carotid or IVC, and radiation exposure and the cost of IR-guided liver biopsy. US-guided liver biopsy has certain advantage, that is you can do multiple procedures, less painful, very good in an anxious patient, very good for the pediatric group where it is difficult for them to breath hold, but the problem is of cost and sedation. This is the study by David Dehel in 8 center 110 patient that shows the EUS guided liver biopsy is safe and efficacious, and in 98% of these patients you can get the adequate pathological sample and one self-limiting bleeding, and there is no major complication. If you look at the recently published meta-analysis comparing the EUS versus percutaneous liver biopsy, and this shows there is no difference in the sample adequacy, diagnostic adequacy, mean number of portal tract and specimen length, but the percutaneous liver biopsy provide a longer non-fragmented, but there is no difference in the sample adequacy and diagnostic accuracy. And how to do the EUS guided liver biopsy? There are various technique related factor. Will you use the 19G needle or 22G needle, or will you use the straight, or you will going to take the biopsy needle, 1 versus 3 passes, dry versus wet suction. And what is the standard is you use the 19G core biopsy needle with the wet suction with the heparinized solution, and you use around 10 cc of negative suction with a single pass and 3 actuation. And before inserting the needle and before withdrawing, you should always apply the Doppler. So once your needle is inside the liver, you puncture, and while withdrawing, you lock the suction, and while going in, you again open it. And once you do 3 actuation, before withdrawing, always apply the Doppler to look for a track of blood. If it is persisting more than 1 minute, then you have to compromise the sample, like in this, or you can change the direction of needle by using the elevator. So make sure that before withdrawing the needle, you make sure that there is no blood signals in the path, and then you remove and expel the material for histopathological examination. The benefit is a safe and provide tissue yield comparable to transjugular and percutaneous biopsy. Is cost saving when you do the multiple procedures in the same sitting, allow bilobar sampling, no pain, you are doing under real time, and patient who is anxious or poor cooperation for the breathing hold, you can do it, and can be done in the obese and a patient who has a mild ascites, less expensive than transjugular liver biopsy, and there's no radiation exposure when you do the transjugular liver biopsy. Now, EUS guided portal pressure measurement, you know that the liver acts as a sleeve, and when the blood flow from portal vein to the liver and to the hepatic vein, and because of the fibrosis, there is a more resistance. and that lead to a portal hypertension, and the normal portal pressure is around 5, and when it is more than 5, it is called as portal hypertension, and more than 10, then it is a clinically significant portal hypertension, where patient can get varices, varicose hemorrhage, and cephalopathy and ascites. So conventionally, you do the IR-guided hepatic venous pressure gradient. You take a catheter from the interjugular vein and you measure the pressure both in the deflated as well as inflated form. And the hepatic venous pressure gradient is wedge minus free hepatic pressure. But the limitation is it is an indirect because you are not measuring direct. Radiation exposure, contrast exposure, costly, and poor assessment of the non-sinusoidal cause of portal hypertension. And now the MESELT is a very common problem, is a major cause of chronic liver disease. And in the MESELT patient, there is an intra-sinusoidal communication that give a false measurement of the portal pressure with the IR guided. While in the endoscopic ultrasound, you can puncture both hepatic veins and the portal vein. That give the direct measurement of the pressure, and the portal vein pressure minus the hepatic vein is the portal pressure gradient. That is more accurate, can be done in the patient who has a pre-sinusoidal cause, or it is more accurate in the patient of MESELT, which is an important cause of chronic liver disease. So I think with the Professor Kenneth Chang, this is a device, a 25 gauge needle with a compact manometer and a non-compressible tube that helps in measuring the portal pressure gradient. And the most important indication is a preoperative clearance for abdominal surgery, or a patient undergoing bariatric surgery or hepatic resection, or a patient who has a liver disease along with require a renal transplant. You can decide the patient should go for a dual or the single. And how you do it? You puncture the middle hepatic vein or the right hepatic or the left hepatic vein with a 25 gauge needle. Transgastric, transhepatic, that's very important. You have to take at least 2 centimeters of the liver parenchyma. And once you puncture the hepatic vein, you flush and take 3 readings, and which should be stable at least for 30 seconds. In this patient, it was 4 millimeter of mercury in the portal vein. And then you find out the umbilicated portion of the portal vein. Here you can see there is an umbilicated portion of the portal vein. Again, puncture, flush it, and take the 3 readings. And in this patient, it was 19. So there is a fluctuation of the needle, but within 1 minute or so, the needle gets stable and it is 19. So this patient has a portal pressure gradient of 15. That indicate this patient has a clinically significant portal hypertension. So this is the first human multi-center studies, 49 patients for the 4 institutions. Technical success was 100%, no procedure-related adverse event, and that shows that higher the mean portal pressure gradient, patient has a clinical features of portal hypertension in the form of esophageal varices, portal hypertensive gastropathy, and thrombocytopenia. And this PPG measurement correlate with the commonly used score of the liver fibrosis in the form of FIB-4, APRI, and the MELD score. This is another very good study where the 11 patients of the end-stage renal disease with a suspected advanced chronic liver disease underwent a PPG measurement, and 10 out of 11 patients as a successful reproducible EUS PPG, and cirrhosis was confirmed in 1, and rest of the patient was able to undergo kidney transplant alone, and that patient required a dual liver transplant. So this is a study in the 30 patients, prospective single center study where they did both HVPG and EUS guided portal pressure gradient, and there is a 1-to-1 correlation. And in a subgroup analysis, a patient of MESELT where the IR guided HVPG has a false result because of the intrasinusoidal communication, and EUS guided PPG was more accurate. So our case, the liver biopsy which was done shows a grade 4 fibrosis, and PPG was 15 and 14. So this patient was prognosticated either he should go for a dual transplant or risk of decomposition after the renal transplant. So future of endohepatology, I think, is going to rise, because for EUS guided liver biopsy, we have a level 1 evidence. It is as good as percutaneous, but definitely a comfort is better in comparison to percutaneous liver biopsy. PPG is as good as HVPG, but better in the MESELT patient. As I've already told, there is an intrasinusoidal communication that lead to a false when you measure the HVPG. EUS guided glue and coil definitely better than endoscopy and promising newcomers for EUS guided shear wave elastography, portal vein sampling, and the liquid biopsy. So I think endohepatology is the one-stop shop. You can do many procedures because this is a common question people are going to ask, what will be the cost? But if you combine many procedures during one these patients, and by that I invite you all for the 7th India-US Summit going to be held on 19 to 21st September from Medanta Institute of Digestive and Hepatobiliary Sciences. Thank you.
There was a nice talk, Dr. Puri. I had a question. When do you not perform US liver biopsy? Would you be concerned in ACLF patients? Of course, standard things being INR greater than 1.6. And
yeah, I think Saurabh is a very
count.
valid, it's the same contraindication as for the percutaneous liver biopsy. Patient who is in coagulopathy, patient who has an ascites, it is better to do the transjugular. So what is the contraindication for percutaneous liver biopsy? Platelet count less than 50,000, INR more than 1.5, or patient has gross ascites, then definitely you are going to avoid the EUS. Or if patient has a dilated intrahepatic ducts, there's another contraindication. So anechoic tubular structure, when it comes during the path of EUS, either a vascular or a biliary, you should not do it.
Thank you.
Rajesh, can I explain? Great talk. Can I just ask about the one-stop shop, the terminology which we are using? Is it slightly misleading? Because there is very rarely we'll be using liver biopsy, gastric viruses injection, all of that in the same patient. Are we just misleading by saying one-stop shop for these procedures?
So in a practical way, yes, I agree with that. But some of the procedure, like patient who has an abnormal liver function test, and you are planning to do the EGD because of a non-specific pain or any reason you are planning to do the EGD. So you are doing EGD, or for a pancreaticobiliary purpose, you are doing endoscopic ultrasound. In the same sitting, you can do a shear wave elastography that doesn't cost anything. You can do the EUS guided liver biopsy. That combination most of the time work, that you are doing EGD or EUS for pancreaticobiliary reason along with the two of these procedures, either a EUS guided liver biopsy or you are doing the shear wave elastography. That is a common scenario you come.
Dr. Puri.
Thank you,
excellent
Rajesh.
Talk. Excellent talk. I just wanted to know that the size of the tissue which we acquire by EUS is probably the same as you get it in the percutaneous. This was the probably conclusion, but you told that you are getting a fragmented liver tissue.
Yeah, so sir, when we do the percutaneous, generally you use the 16 gauge needle, and here we are using the 19 gauge needle. And the most important thing while doing, you can get a non-fragmented sample. The fragmentation generally happen when you want to expel the material, and the people try to use the stillet. It is always better try to flush with the saline. That's one. And number second, don't make too many actuation, because as an habit like an FNA, people keep on doing the 5 to 6 actuation and you will get a bloody specimen. And when you try to separate the blood from the main core tissue, the tissue gets fragmented. So 3 actuation is good. And number second important thing, while going in, you on the suction, and while withdrawing, it is better you off the suction. So this is the way you can make possible that the specimen should not be bloody. And while expelling the material, you expel with the water. Water means saline rather than using the stillet. These are the 2 places where the risk of fragmentation is there.
Thank you, Rajesh. It was a lovely talk, and I was so happy to see in an endoscopy meeting a slide on HVPG and discussion on limitations of HVPG. So I think that was really encouraging. I'm sure it is going to definitely increase the role of endohepatology in the future, especially US biopsy. And another thing, I think a natural byproduct of this, I'm sure we are going to have many, many more liver biopsies in general because of this. So I am already seeing increased demand for liver pathologists now, because now endoscopists are also doing liver biopsies. So,
and
so
one
thank
of the
you,
more,
Rajesh.
Yeah, because this can be done via one doctor who is treating the patient rather than sending the patient to the IR. and a busy tertiary care center when the patient get the date after a few days. So in the one setting you can do, and for liver biopsy, anxious patient and the post-procedure pain is not there. That is one of the biggest advantage, and you can give the equally good tissue.
Sir, we've run out of time for this
Thank you.
lecture.
Thank you.
So it's my great pleasure to invite the next speaker, Dr. Anil Arora, who will be speaking on ERCP in post-liver transplant strictures. So,
are you okay?
He is the ex-president of Indian Association for Study of Liver and comes from...
Thank you, sir. At the outset, I am extremely thankful to Dr. Amit for giving me this opportunity. This talk, which I have been hearing for so long, has been traditionally delivered by my boss, Dr. Randhir, who luckily is in the audience. For a change, I have been allotted this talk. Let me see if I can do the justice. Whenever you do a liver transplantation, by default, you are going to anastomose a number of the vessels which are arterial, venous, as well as the biliary anastomosis. That is what leads to the complications. And if you look at the timeline of complications, especially the biliary complication, depending upon at what time does the patient present to you, you can either have bile leak, anastomotic strictures, non-anastomotic strictures, as well as ampullary dysfunction. So depending upon the timing after which the patient presents to you with a bile leak and or stricture, you can try to see as to what is happening to the patient. Overall, the incidence of biliary complication is far more in the LDLT as expected, because you are trying to anastomose half of the liver with the native remaining bile ducts. So the overall anastomotic incidences in DDLT is around 10%, but it is almost 2 to 3 times in patients who undergo LDLT program. So if a patient has an LDLT, the chance of having a biliary complication is almost 3 times. Mean time to develop stricture is the same in the two situations, and the likelihood of response to ERCP is far more in the DDLT than in the LDLT group, and overall the number of the sessions required to take care of these strictures is almost the same. Most of us tend to say that biliary complications is basically an Achilles heel of liver transplantation. Let me try to look at, if you Google the meaning of Achilles heel, it is by default a weakness despite overall strength, which can lead to a downfall. So this is a burly man. He just has a pain in the heel. While this mythological origin refers to the physical vulnerability, but then idiomatically we refer to a number of other conditions when we say, though this patient has an Achilles heel. What are the factors which lead to occurrence of biliary strictures? You can have a bile leak, and bile leak by default will induce inflammation and subsequent fibrosis. It is a surrogate marker of poor vascularity. Then the number of the anastomosis and whether the anastomosis has been done with a cystic duct will lead to more stricture formation. The older the donor, it's very likely that you have presence of the degenerative age-related changes in the microcirculation of the biliary tract, which will lead to development of the stricture. And in DDLT setting, if you have a combination of the prolonged cold as well as the warm ischemia, you are more likely to have strictures in the biliary tract. So whenever you try to handle a patient of liver transplantation with biliary tract, you try to delineate and try to classify the stricture as being anastomotic or non-anastomotic. Anastomotic strictures are more likely to occur in LDLT setting. They are related to the surgical technique, including the number of the anastomosis, ischemia time, as well as its relationship to the bile leak, as well as the altered anatomy. Whereas non-anastomotic strictures, which are far more difficult to manage, are more likely to occur in DDLT. They are typically longer, they are multiple, and may be related either to the macroangiopathic changes like hepatic artery thrombosis or microangiopathic injury to the endothelium of the supplying blood vessels, that is cold ischemia time, and at times they may be related to the immunological injury. So this is what a anastomotic versus a non-anastomotic strictures look like. Anastomotic strictures are typically single, they are short, they are within 0.5 to 1 centimeter of the anastomotic site, whereas non-anastomotic strictures are typically long, they are multiple, and they are by default 1 centimeter proximal to the anastomotic site. They may be intra or extrahepatic, primarily they are the prehepatic type. Moreover, if you look at the outcome of the patient with anastomotic strictures, majority of them will respond to endotherapy. They rarely lead to graft loss. But if you look at the non-anastomotic strictures, which are multiple, long, and intrahepatic, they have a poor prognosis because they are not only difficult to treat, but in 30% of the time, because of the multiparity, they are likely to have graft loss. So we suspect a patient to be having a post-transplant biliary stricture whenever the patient has altered liver function test or fever or cholangitis. Ultrasound has a poor sensitivity, but typically the diagnosis is made by demonstration of the dilated intrahepatic biliary system using a technique called MRCP. ERCP, as of today, is hardly ever used for diagnosis of the biliary stricture. Whenever you are trying to use ERCP, it has to be for a therapeutic purposes. MRCP finding with abnormal liver function should lead an ERCP as a therapeutic option as a first-line management. The management of post-transplant biliary stricture typically will involve ERCP as the first-line modality, and if one does not succeed, then you have to bank upon BD-guided or percutaneous intervention, and finally surgery may be the answer in patient in which both of these fails. There are some technical considerations which you have to remember when you are trying to handle post-transplant biliary stricture. In general, the principles of the management are the same as you are dealing with any post-cholecystectomy biliary strictures. MRCP is a prerequisite in all patients before you go in for therapeutic intervention. You have to make an attempt to make the type of anastomotic stricture, whether it is an anastomotic versus non-anastomotic stricture. There is a good role of procedural antibiotics. Balloon dilatation alone is not sufficient. It almost always has to be accompanied with placement of the stent. You will require to have multiple sessions, generally 3 to 4, and the proper assessment of the remodeling of the stricture has to be done every time you go and do the intervention. Overall, if you look at the results, 90% of the patient, 80 to 90% of the patient will have resolution of the symptoms within average of about 4.2 sessions per patient. And the chance of recurrence is less than 10% if you follow up these patients after prolonged endoscopic therapy over the next 10 years. So this is how anastomotic strictures look like. You go and do a biliary dilatation, put in multiple stents, and that is what it leads to. This is the typical anastomotic strictures. DDLT strictures, biliary strictures are easier to treat endoscopically. They have a high success rate. In case after 2 or 3 attempts, if still you continue to have a stricture, there is a recent suggestion that at least in the extrahepatic biliary stricture, you can place a covered self-expanding metallic stent. So this is what happens typically. You have an anastomotic stricture. You keep on putting increasing number of the stents, and ultimately you end up achieving a completely normal bile duct. In fact, in the literature, people have put in as many as 9 stents sequentially over a period of time. So LDLT strictures are slightly more difficult because they are usually at an angulation. Their anatomy is complex. They are typically peripherally located. You can have involvement of the multiple smaller ducts because you are anastomosing half of the liver to the native bile ducts. And you need far more aggressive endotherapy in patients with the LDLT strictures compared with the DDLT strictures. Most difficult strictures are the strictures which I have already mentioned as a non-anastomotic strictures. They occur above the anastomosis, at least 1 centimeter above the anastomosis. They are multiple. They are far more difficult because they are angulated. So overall, the success rate of endotherapy is quite poor compared to the anastomotic strictures, and it may take much longer time for the strictures to respond to your endotherapy, as many as 30% of the patient may end up losing a graft, which is something which is very critical to remember. There are some challenges when you are trying to treat LDLT related strictures. There may be special circumstances like spectacle anastomosis, cystic duct anastomosis, or the strictures may be too tight and not amenable to endotherapy. For these special situations, you may have to be equipped with special strategies to manage them, which may include special guide wires, a Sohendra pancreatic dilator, cystotome, or you may need to use a fully covered metallic stent. And certainly 30% of these patients may also need the assistance of the PTBD guided drainage to help you out. So this is the case in which it was difficult to place a guide wire. So you may need to put in 2 stents, and then finally, once the patient does not respond, you may have to bank upon self-expanding metallic stent, which can be put in situ for as long as 6 months before it takes its effect. So there is recent data to show that there is a special stent called CAFE stent, which has a retrievable lasso, in which the migration rate may not be very high, and even though the resolution of the stenting, the resolution of the stricture has not shown to be superior to the plastic stent, but the number of the sessions needed to treat biliary stricture is less in patients with the fully expanding metallic stent. This is a recent publication from NHS in Singapore, in which they have used a 3D fluoroscopic intervention to selectively go into the anterior or posterior duct, because the typical fluoroscopy which we use is a 2-dimensional fluoroscopy, in which you may not be sure that which duct you are entering. So this is a slightly longish video, I will not be going into the details, but a 3D fluoroscopy can at times be handy when you have strictures which are located in a duct which may not be easily discernible on 2D fluoroscopy. So this is what can be done in a situation like this. You may need the help of a PTBD catheter to get into the biliary system. And finally, this spyglass cholangioscopy is something which is recently coming into being. We have been having multiple demonstrations of this technique in management of biliary strictures, but suffice it to say there are 2 types of pattern which are seen in patient with the post-LDAT stricture. In type 1 cholangioscopic pattern, you can see a smooth stricture without an ulceration. Now, this is the stricture which is very likely to respond to endotherapy. But in patients who have a stricture which is ulcerated and which is longish, this is a stricture which is likely to require long-term management with multiple stents. So a type A pattern on cholangioscopy will respond far better to type 2 pattern in patients with the post-LDLT strictures. PTBD is always a part and parcel of the procedure, and 30% of the patient, especially with a non-anastomotic stricture, may require the intervention of the PTBD guide to help us out. Dr. Sanjay did demonstrate about the magnetic compression anastomosis. There is already a publication from Dr. Sung's group that if you use one catheter through the PTBD system, another through the native bile duct, there is a good anastomosis using this magnetic compression, and you can achieve a good result of trying to have a recent anastomosis between the bile duct and the obstructed proximal duct. There is some data to show that if you try to put in the stent into the biliary system away from the ampulla without doing a papillotomy and leaving a lasso for the dragging out the lasso stent, the results may be better, but the jury is still out, and there is no definite recommendation of leaving an intraductal papillary stent. So finally, coming back to the Achilles heel, then once we have a combination of spyglass cholangioscopy, PTBD catheter, magnetic compression, even if there has been an injury to the ruptured Achilles tendon, we as a team can go and repair the tendon and send the patient back home safely. To sum up, ladies and gentlemen, post-LDLT biliary strictures are difficult strictures to manage endoscopically. Aggressive plastic stenting results in a success rate of more than 85%, and still plastic stenting continues to be the mainstay of the therapy. The strictures which are complex, which involve the small ducts, which are angulated, which are very tight, and especially the non-anastomotic stricture, they present bigger challenges in management of these procedures. Thermal stricturoplasty as well as the magnetic compression anastomosis are the emerging innovative approaches in management of these patients, and ultimately a teamwork involving an interventional radiologist as well as the surgeon may be handy in management of these patients. Thank you.
Thank you, Dr. Anil, for this lucid talk. Since we are almost half an hour behind schedule, we will close this session. If you have any questions, you can ask Dr. Anil.
We have 2 minutes for questions and discussion, sir. We have.
Any questions from the floor?
I would just like to ask, who should be treating these patients for the ERCP and the intervention? The Lone Ranger endoscopist who may have referred the patient for liver transplant, or a specialized center, high volume center which deals with this?
I think most of the procedures which most of the centers which are already doing LDLT program, they have to have an expert ERCP guy to do this procedure. Because as I said, compared to the post-cholecystectomy strictures, these are far more difficult to treat because of the angulation, because of the multiplicity of the lesion, as well as because of the need for a teamwork. So most of the LDLT center should have an experienced ERCP guy doing it.
So are there any tips or tricks to prevent restructuring of a reformed anastomotic structure?
To prevent, yes, that is very important. You know, one is that because of the time constraint, I didn't mention the ways of preventing the stricture. One is if you handle the bile leak earlier, the earlier you handle the bile leak, whether it is from the cut surface or a cystic duct stump leak, the more the chances are you will be able to prevent the infection. Because 30% of the time, bile leak per se will induce fibrosis and stricture. So first is the management of the bile leak. Secondly, once you are anastomosing the bile duct, then lesser traction you have on the peribiliary plexus which supplies the bile duct. So if there is a persistent pressure with the surgeon or pulling on the anastomotic site, that leads to injury to the peribiliary plexus which is supplying the bile duct. That is something which can be avoided. So prolonged traction as well as early management of the bile duct can be easily done to prevent the occurrence of the biliary stricture. Non-anastomotic strictures are something which are related to prolonged ischemia and as well as prolonged warm ischemia and as well as a cold ischemia. There is a recent concept to show that if you use a deoxygenated blood for the perfusion of the liver prior to transplantation, that decreases the incidence of non-anastomotic strictures to almost zero. So if machine perfusion is something which is far more relevant than the leaving it to the human beings, which will have a variable duration of prolonged and the warm ischemia.
Hello, thank you, sir. Excellent talk, sir. Dr. Sidhu here. Hello, sir. Sir, if there is tight stricture, we are able to pass the guide wire, but not able to negotiate with end dilator or cystotome. Then what can be the option other than magnet if it's like it's not available?
Yeah, so there are three ways by which you can do it. One is that you can use a stricturoplasty. You can use a magnetic anastomosis, you can use a cystotome, and you can use a percutaneous approach. If all of three things fail, then surgery is the only answer. There are three ways you can try to handle it. Usually stricturoplasty using a cystostome, see you have a proximal tip, you have a distal tip. You can use a cystotome to connect the two. Typically it's not done in a benign condition. It's usually done in a malignant condition. But as a last ditch effort, you can use it. Other than that, if everything fails, surgery is the only answer. Otherwise, you're going to lose the graft.
Thank you, sir.
Thank you, Dr. Anil Arora, and I thank all the chairpersons for chairing this last endoscopy update. Ladies and gentlemen, let us now experience some candid moments of the conference. Try and spot yourself somewhere. These are all candid moments.
Dear friends, it gives me great pleasure to welcome all of you to Mumbai for the 22nd edition of the Mumbai Live Endoscopy Conference. This is a proud moment for the Reliance Foundation Hospital. My hearty congratulations to Dr. Amit for this effective initiative. He is the guiding force behind our investment.
I guess Steven and I are first time to join the Mumbai Live. We've heard so much about it. It's one of the biggest events in India about live endoscopy. This is all orchestrated by him like a Bollywood film. So I hope every year there's a new Bollywood film coming with every year's Mumbai Live. So I do look forward to come back, hopefully every year.
Yeah,
Yeah,
very much
so thank you very much.
I'm sure you must have spotted yourself somewhere. Anyway, without wasting any more time, I welcome you now to the final Mumbai Live oration. And as chairpersons, I would like to invite Dr. Amit Maidev, Dr. Chris Kaur, Dr. Randhir Sood, and Dr. Nageshwar Reddy to please come up on stage and invite and introduce our esteemed speaker. Over to you, sir.
Good afternoon, everybody. And I think in every conference, the best is always reserved for the last. So we have great pleasure among the moderators here to invite one of the most distinguished endoscopists in the world, Dr. Pratik Sharma, to give us this talk on work that he's been doing for a very long time now, artificial intelligence GI endoscopy. As Pratik is coming up to the stage, he is, of course, one of the world's authority on the esophagus, Barrett's, GERD, has been responsible for many classifications of, like the Prague classification, the BEST, and so on. He is also, I think, as Indians, we're proud to say, the first Indian president, or the first Indian who's been the president of the American Society of GI Endoscopy. Pratik, it's a great honor for us to have you here to deliver this Mumbai Oration 3.
Okay. Thank you, and good afternoon, everybody. And of course, first, my congratulations to Amit for such a wonderful production. And of course, we are pleased to be the actors in your movie, Amit. So fortunately, we don't charge as much as the Bollywood stars. So that's actually good. So Amit gave me a title of looking into the future with artificial intelligence. So I'll spend some time just telling you what my concept is. Of course, this is an ever-evolving field, and very soon, by next week, this may become defunct as well. So if we look at what's happening with digitizing your industry, healthcare still is at the bottom part of the field. So if you look at banks, you look at the financial sector, you look at other industries, they're much more advanced in this field of digitization, which is what you need for AI to be active. And so we do have a significant potential to improve. And you look at what are some of the major areas where the improvement can be, I think we have to still remember that the patient should be at the center of healthcare and interoperability. We have to drive better outcomes with machine learning. We need to enable AI in healthcare, and of course now with cloud-based systems and GPUs becoming a little less cheaper, this can be achieved. Improving access to care by digital transformation. And finally, I think some points which I'll touch upon are important for all of us as physicians, is to reduce physician burnout and fatigue. We heard that how many sleepless nights Amit spent, but in the future, can he use AI to his advantage so that he does not have to do several of these tasks that he physically had to be here to do? So let's look at the different types of AI. Narrow AI, in which AI can do just one specific task, which is where most of the things happen. Human level AI is more general, so it's general artificial intelligence, and then in the future, the goal is to be in super AI mode, in which, with the help of these supercomputers, we may be able to get to the stage where the AI becomes much smarter than human beings as well. And this is where we are, so we have to look at the journey forward of what can be happening. So if you focus this on endoscopy, there are different levels of automation which can happen. Level 1 is simple detection and characterization of lesions. Level 2 will be a point where endotherapy can be automated with the help of the operator. Level 3, level 4, level 5 is hopefully we will not require, where physicians or endoscopists may not be required, and everything is done with the help of artificial intelligence. And level 1 is where we are currently with narrow artificial intelligence in the field of endoscopy. So then let's spend a few minutes looking at these different areas of the future of how things may evolve in AI and healthcare. And I'm going to talk about healthcare in general and not just specifically endoscopy. Let's start with computer vision. And this is a field of AI in which imaging drives everything that we do. So for example, you can look at a system in which it's giving you the size of the lesion, the nice classification, but it's also guiding you whether this lesion is suitable for endoscopic resection or not. So it's one step above just detection and characterization is what can happen with this. And so the computer is guiding you whether a lesion should be attempted for endoscopic resection or not. So this is something that we can look forward to. This is how robots and AI can work together. This is in the field of surgery, in which this is robotic-assisted surgery, but now with the help of artificial intelligence, it's actually marking the exact area where those incisions should be made. And with the help of virtual reality, it is going to tell you exactly where the different organs can be faced in this situation. So for surgery and endoscopy, this is something for the future which will be available. This is for radiology, virtual reality in diagnostics. So this is true if you wear those Apple Vision Pro goggles. You can look at the images and then you can move them around real time. You can sagittally cut them as you want them. And you can look at the 3D anatomy, but also real time for all these images. And with the help of your fingers, you can move all these images around. So virtual reality in diagnostics will be here very soon. That's virtual reality. Augmented reality means in which you are able to control the different levels that you want. So for teaching our students in anatomy, for example, and for teaching them endoscopic procedures, you can use these cyber knives, and you can see exactly where the incision needs to be made. And this is all happening in the field of surgery, but it's very soon that doing third space endoscopy, teaching our endoscopists, we'll be able to do this outside of patients in 3D modes with the help of augmented reality in this situation. This is again the future of teaching anatomy of the GI tract to all of our students, in which they can look at it. Cadavers will be a thing of the past. And not only can you do that, but you will be able to look at all different organ systems live with the patient. Here, this is a hologram in which the physician is somewhere else and the patient is somewhere else, but they're looking as if they're facing each other face to face. Similar concept of IR-guided interventions are happening, in which you'll be able to look at the images in front of you real time, and you will be able to cannulate the different vessels. And again, very soon this can be applied to endoscopy as well. Also, you can use vision in your hospitals for hospital hygiene, for example. Cameras are mounted everywhere, and you can spot where the trash is. You can spot whether people are wearing masks, where they're supposed to be wearing or not, and this can be tracked real time for your hospital system, which can be done. So this is using computer vision for the future. How about personalizing medicine? And how about being able to provide some personalized remote care for our patients? This is again, a patient is in the home with their iPad, and this is the nurse giving them instructions remotely. Step on the scale, measure your body weight, and they are able to input that into it. The patient can measure their blood pressure, which right now can require a manual cuff. And this can be done all remotely with the help of either an iPad or with the help of a smartphone. So for simple measurements like checking somebody's blood pressure and giving them instructions on how to take their medications, a hospital visit or an OPD is no longer going to be required into the future. And just by a patient sitting in their bedroom, will be able to access all of this. This is telling you how a health scanning cameras are now available. And what this does is that it reveals the pulse, vital scans, just from patients' facial recognition. So this can all be done remotely and with the help of artificial intelligence. Wearable technology will be a thing of the future, in which all of us will have technologies on us which will be talking to the healthcare system. Whether you have a smart ring that you're wearing, the ring is transmitting signals. Whether you like diamond bracelets, like Nilima does, I mean, that will be transmitting signals. Or you're wearing smart shoes, as athletes do, they will transmit signals continuously. So the thing for the future will not be patient visit data every 3 months, but it will be continuous monitoring of these signals from it. This will lead to decision support systems. So all those things that I just showed you will go into the healthcare record of the patient being transmitted from wherever you are. So you can see these different maps in which patient symptoms are being transmitted. And these can provide real-time feedback to your physicians, who can be sitting either at their home, they can be somewhere on vacation, and they can be looking at their smartphone, and all these different sets of information are being provided to them. The other thing for the future will be multimodal approach to disease states. Right now, we are very focused on endoscopic imaging as endoscopists. When we are doing endoscopy, we are just looking at the image. We forget what the patient's gender is, what their proteomics are, what their lab values are. We know that they exist, but we are not putting them all together. So let's look at IBD as an example. So if you're performing endoscopy, you can use computer vision to tell you what the scoring system is. You don't have to memorize it. So that goes into the patient's chart. Then you will have different biologic agents, and you can predict their response to therapy based on just 4 weeks or 1 week of data, and you don't have to wait to give a patient a biologic for 8 weeks to see response. And these are studies which show that this can be done. So now you have endoscopic data. You know how good or bad a patient will respond to a biologic with just 1 week worth of data. Then you will have all these computer-assisted conversations with the patient which are happening. Right now, we don't do that. When I was doing a case of a patient with Barrett's, I had no idea what the conversation of Amit was with that patient 3 days ago. So we need to put all of those things together as well. Then you have all these different notes, which may be handwritten, which may be patient symptoms which are being generated. And these can be using natural language processing. These can go into different buckets of this patient. So what AI can do is transform unstructured data into structured data for you. So this is how that IBD practice will look. You look at conventional, what we do present, and then on the right is what's the future of AI care for IBD patients with it. So you're getting a 360-degree view of the patient. You go into the office or the patient is remote. You just say, Siri, pull up the patient's last endoscopy report. That comes up on one screen. Siri, pull up the last conversation the patient had with a nurse or with another physician. That comes up. So that's the multimodal data that we need to treat a patient or holistic approach which will happen. So that's patient care. Let's move on to education and research and a peek into the future with it. If you can hear this.
X equal 3. What do you think we should do next to solve
this is a chat GPT of the future, which is image driven.
3x and you want to find the value of x. Think about what operation would undo multiplication.
Is it subtraction?
Close, but think of the opposite of multiplication, because 3x means 3 times x.
Okay, I think it's division. Let me try to divide both sides by 3 and let me see what I get.
Bingo! Go ahead and divide both sides by 3.
Okay, so ChatGPT, this is what I ended up with. How does this look?
It looks perfect. You've solved it, and x equals 1. Nicely done. How do you feel about
Okay, so right now we are used to ChatGPT, just typing in those answers. In the future, you'll be able to show ChatGPT a problem visually, and it will solve it, and it will prompt you to do it. So you'll be able to teach the next generation of students with the help of these visual clues in which they will be given prompts on how to do that. Now, this is something which is available right now that all of you can do, is you can type in, create an image of a 14-year-old boy playing soccer in a field. And I'm doing this and I'm recording this live. This is a paid version right now of a large language model. So you give it about 30 seconds and it will print this image for you. And you know that right now you can look at endoscopic images, you can feed it in, or you can say create an image of a polyp or of a Barrett's esophagus or for hilar stricture. So this is how education and training can be done today and in the future with the help of it. So this is the patient data of the future, is you're looking at all invisible data points, which is continuously being generated by the patient. Also for the future, clinical trials will be easier to do. For example, you can create an external control arm. Right now, if you wanted to do an IBD trial, you do a randomized controlled trial of a new drug versus placebo. Here's looking at an AI-generated control arm from your own electronic health record system. So this is an example of a Trident study, which was done for looking at a biologic for Crohn's disease. And then they looked at the UCSF patient database, and they looked and matched the patients according to the same trial, and they gave the data that in your UCSF population, if you were to treat the same patients with this biologic, they would have 34% remission at week 24. So this is how in the future you can look at whether it's Reliance Hospital or AIG Hospital or Randir's Hospital, you will be able to know what your patient's response to a particular drug will be, rather than what had happened in a study which was done in the US or in the UK. Finally, implementation of AI still continues to be a problem, and there really aren't good guidelines or policies around it. US also still doesn't have a policy of AI in healthcare, and I think that needs to be done. And I think we've been talking to the government in India to have something similar, because policy will drive how AI in healthcare will be done for the future. Also, I've shown you all the great things that AI can do, but still it will happen, unfortunately, at a very slow pace, because there are a lot of these barriers to implementation, because all these algorithms that we have will have their own inherent limitations. Data is prime, but access is of importance. Regulation has its own problems and challenges. And of course, we want to make sure that everybody is aligned in how to use this best. And so we need to all work together to make sure that this can happen. So it's this whole ecosystem we have to create of physicians, regulators, industry, government, policymakers, etc., to do it. Have to remember that healthcare, unlike other tech industry, is something which is very private, which is very important, and data security can never be violated for our patients. So whatever we do, we need to have these. So how is your data stored in all of your institutions? How safe is it? Who has access to it? We have to ensure that that happens. You have to re-identification and de-identification of data needs to happen at all of these. And the concentration of this will happen with big tech. So we need to have them responsible and make sure that they do it in a reasonable way. And of course, monetization and penalties need to be in place. Everybody talks about the legal aspects of this. So we need to go back to our principles of what we need to do in taking care of our patients, and go back to our patients which are listed right there, and make sure that as physicians, all these principles are looked upon very importantly with all of these patients, to make sure that AI is engaged, but is transparent, but is also held accountable for all what we do in there. So finally, we've talked about a lot of these things, but when you talk to physicians and you look at what are the important applications that could change healthcare in the future, it's not direct patient care, but it's always indirect patient care, which is virtual nurse assistants, administrative and workflow solutions, reducing medication error, connecting machines properly, clinical trial participation. So that's the crux of what actually people want. It's not detecting that one additional polyp or a malignant stricture. We think that's important, but that's really not what people want to do for the future. So in the future, if we can outsource a lot of these tasks, we can automate that, we have that opportunity to restore that human bond. And the biggest gift I think AI will give us in the future will be the gift of time, so that we can spend time more with the patients, more with our family, and more for the betterment of healthcare rather than on some of these mundane tasks. Thank you all very much for your attention.
Well, Pratik, thank you so much. I've listened to you so many times on a lecture of artificial intelligence, AI, but I'll tell you, this was one of the best from what you have spoken till now. Very, very comprehensive. You have covered everything. In fact, I feel that now you have got so much of insight in AI that if this lecture is heard by our Prime Minister, Mr. Modi, he'll definitely make you the chief consultant for AI for India. So thank you so much, Pratik. We are not going to have any questions. And thanks for coming once again and gracing this occasion. Thank you,
you all very
Pratik.
much.
See you
Thank you.
soon. I would, as we come to the end of this program, I would like to request Randhir as well as Chris as well as Nagi to remain sitting here, because now we come to the ultimate finale. That is the climax, because we are going to give away the prizes for the Kaun Banega Endoscopist video contest. And for that, I would like to first call, let's go there.
Are the contestants in the hall? Raise your hands. They're not there?
And as I had mentioned before, your presence is very important for you to get the prize. So we had specifically requested all the video contests participants to remain in audience till the end. So hopefully they are there. So first let's start with the, pardon? Let's start with the bronze medal. That is the third prize. Bronze medal will go to Dr. Harsh Jain from Delhi.
Is Dr. Harsh here?
Is he there or
Come
not?
forward. Congratulations, Dr. Harsh. He's walking forward. We can have a louder round of applause.
Dr.
I know you
Nageshwar
are
Reddy
all
to please give the prize.
hypoglycemic.
And the third prize is, they are going to be AirPods from Apple.
Congratulations.
The Kaun Banega Endoscopist video contest was supported by Boston Scientific. And now we come to the second prize, that is a silver medal. That goes to Dr. Priscilla Lopez from Hyderabad, from AIG. I would like to request Dr. Randhir Sood to please give this prize. And this is going to be an iWatch from Apple.
Congratulations, Dr. Priscilla.
And now we come to the gold medal, the first prize. The first prize goes to Dr. Shubham Mehta from Delhi. I request Dr. Chris Ford to give the prize.
Congratulations. Well done.
And this prize is a MacBook Air from
Wow.
Apple. Thank you so much. Thank you.
I thank all the chairpersons for chairing the oration, and may I request Dr. Maidev, sir, you're having a picture? Oh, sir, your closing remarks, if any? I request Dr. Amit Maidev to give his closing remarks.
There are no special closing remarks from my side because we have already come to the end and the climax of the whole thing. And I just want to say that I'm eagerly waiting to see you probably next year, not for Mumbai Live, but maybe for ERCP Live. But the Mumbai Live will come 1 year later. That is probably in 2027.
Thank you, ladies and gentlemen. We come to the end of this highly intellectual and deeply engaging and insightful academic treat. I thank you all once again for your wholehearted participation, and I wish safe travels to those who have to travel back home. I take your leave now and invite you all for lunch. Thank you very much.